Okay. Good afternoon.
Good afternoon.
Thank you all for your patience. We were waiting for a quorum. Today is Tuesday, February 18th. Thank you for joining the Finance Committee. I'm Pam Vidal, Chair of the committee, and with me is my Vice Chair and the rest of the committee, so thank you all for being here with us. We have a bill order, and it's due to change because the senators that are out are in other committees testifying on bills, so we just have to work with everybody else's schedule. But we're going to start with Senate Bill 433. Our Lieutenant Governor is here for that bill. And then we're going to do Senate Bill 684, 589, 592, 674, 696, 679, 594, 793, 981, and 676, all subject to change depending on senators' availability. Sponsors, you have as much time as you need to present your bill. Panel members, please keep your testimony to 2 minutes. We will appreciate it. So very nice to see you, Madam Lieutenant Governor, and thank you for being here today, and you can begin.
All right. Well, thank you so much for having me here, Chair Vidal and Vice Chair Hayes and members of the Finance Committee. And hearty congratulations to your newly minted Senator, Carl Jackson. It's great to have you here. I'm Aruna Miller, Lieutenant Governor of Maryland, and I'm here to testify in strong support of our administration's Senate Bill 433, Office of Disability Employment Advancement and Policy, and Maryland as a model employer initiative. So what is the purpose of Senate Bill 433? Maryland faces a workforce crisis. For every 100 jobs that are available, there are only 40 available workers to fill them. Yet there is an untapped talent pool being overlooked, and those are Marylanders with disabilities. Today, only 45% of working-age Marylanders with disabilities are employed, compared to 79% of those without disabilities. That's not just a disparity. It's a missed opportunity for our state, our economy, and our people. Senate Bill 433 is about recognizing talent, removing barriers, and ensuring Maryland's workforce reflects the full potential of its people. When we invest in hiring individuals with disabilities, we don't just fill jobs. We strengthen the organizations and improve outcomes for everyone in tangible ways. Individuals with disabilities seek stable, long-term employment, leading to higher retention rates and lower organizational turnover. Their unique life experiences bring a wide range of perspectives to the table. This leads to greater innovation, better problem solving, and more effective public services. But this isn't just about public service jobs. When Maryland leads, the private sector follows. By prioritizing inclusive hiring, we send a clear message that this is good for businesses. Employers that embrace disability inclusion outperform their competitors with higher productivity, stronger employee engagement, and a workforce that reflects the community that it serves. And here's the thing, when we create workplaces that welcome individuals of differing abilities, something remarkable happens. It transforms the entire workplace for the better. We cultivate a culture of compassion, patience, and empathy. We become better colleagues, stronger leaders, and better human beings. Maryland has an opportunity to lead by example, not just by checking a box, but by truly embracing the talents and contributions of all. Senate Bill 433 applies key lessons from the National Governors Association's Disability Inclusive Workplace Policy Learning Collaborative to position Maryland as a model employer. The bill establishes an office within the Maryland Department of Disabilities to lead this effort. This office will enhance the department's ability to support programs, coordinate policies, conduct research, and manage grants, ensuring greater employment opportunities and improved outcomes for people with disabilities across the state. The office will implement State as a Model Employer initiative in FY 2027. Now, I've seen firsthand how powerful it is to give people with disability a chance to show their skills and their talents. When I worked as an engineer for Montgomery County DOT, the county launched what was called the Project Search program under County Executive Ike Leggett. This program provided job training for young adults with intellectual and developmental disabilities. And this is where I met Vineet, a fun-loving, inquisitive, a smart young man, and a die-hard Commanders fan. But helping Vineet navigate the hurdles of employment wasn't easy. For over a year, I advocated tirelessly to give him the opportunity that he so much deserved. And when he was finally offered a full-time job, it wasn't just a win for him, it was a win for his workplace. 10 years later, today, Vineet is still thriving at Montgomery County DOT. His colleagues love him. He cherishes his independence, and yes, he's still a die-hard Commanders fan, which is a test to his resilience. He was ecstatic to see them get so close to the Super Bowl. Vineet's story shouldn't be the exception. It should be the norm. Disability isn't about a person's abilities. It's more about the barriers created by an environment that is not accessible, inclusive, or intentionally designed. With Senate Bill 433, we can change that. I urge your favorable report on Senate Bill 433. Thank you.
Thank you. Senator Kramer, you have a question?
Thank you, Madam Chair. Lieutenant Governor, always a pleasure to see you. And, you know, reading through the legislation, I would love to see if the new unit within the Department of Disabilities will be able to provide some feedback, because while I was still a member of the House of Delegates, I sponsored 2 successful bills on this subject matter, one of which requires every state agency in the state to give a preferential hiring to a resident with a disability. And I'd be very curious to see if the department has ever at any time followed up to see if in fact that is being properly implemented, and what the success might be of ensuring that we are doing just that, and if there is any effort to market to our residents the fact that the state of Maryland is taking the lead to demonstrate its interest and efforts to ensure that our residents with disabilities are not overlooked, and to let them know that if they are interested in state employment, that they will be given a preference as long as they're capable of fulfilling the job description of that particular position. The other was the other bill provides a tax credit to private businesses that hire an individual with a disability. And once again, I would welcome the opportunity to get feedback as to whether this is also something being successfully implemented, and if in fact it's, you know, being marketed. Sometimes we do great things and they're kept very secretive, and so our residents don't know that there are these opportunities, or perhaps the business community might not be aware that if they hire someone with a disability to fulfill a job in the private sector, that business is eligible for state tax credits. So kudos on the effort of the administration here. Very important issue. So thank you for your attention to this important matter, and looking forward to successful implementation. Thank you, Madam Chair.
Thank you, Senator. Do I have any other questions for the Lieutenant Governor? Seeing no questions, thank you for your testimony.
Sure.
Are you bringing up Secretary Carol Beatty, or is she just here to support? Senator Beatty, you want to come and share some words? And then June Chung, are you coming to the table? Thank you. That will finish panel one.
Thank you, Lieutenant Governor, for the introduction and for joining us here today on the panel. And Chair Beidel, Vice Chair Hayes, and members of the Senate Finance Committee, I'm Carol Beatty. I'm the Secretary of the Department of Disabilities, and it's an honor to be here with you this afternoon. I'm here today to ask for your support of Senate Bill 433, establishing the Office of Disability Employment Advancement and Policy as part of the governor's package of legislation. I'm very grateful to be part of an administration that sees disability employment as a key component of Maryland's economic growth. The work of this proposed office will build on the coordination function that we have provided to increase employment opportunities for people with disabilities since the establishment of our department 21 years ago. As you heard in the Lieutenant Governor's testimony, many state agency partners were involved in the planning of this initiative and are prepared to support the work should this legislation pass. And based on our work together and the experiences of other states, it is clear that a whole of government approach to advancing the employment of people with disabilities is the most successful approach. More needs to be done to make state employment a realistic goal for qualified individuals with disabilities. Jay Gingrich, who is the department's Director of Employment and Transition Policy, and she was the lead for Maryland's NGA team. She's here today to help answer questions from the committee. Again, I'm very grateful to Governor Moore and to Lieutenant Governor Millers for their leadership on this issue, which is of great importance to the disability community, and we ask for the committee's favorable report.
Thank you, Secretary. Do I have any questions for Secretary Beatty? Seeing none. June, are you testifying?
Nope, I just have, I'm just here, I submitted my written testimony, and we do actually have a second sponsor panel of like
Yes, you
four.
do. I have that.
Okay, great, thank you.
So
Madam Chair.
seeing no questions for this panel, thank you very much. The next panel is Rachel London, Ronza Othman, Bong Della Rosario, and English Harper. Please come to the table.
Thank you.
Who would like to start? Rachel?
It's me. Okay, you're good. Okay. Good afternoon, Madam Chair, Mr. Vice Chair, and members of the committee. My name is Ronza Othman, and I serve as president of the National Federation of the Blind of Maryland, which is the state's oldest and largest advocacy organization of and for blind, low vision, and deaf-blind individuals. I'm also a federal employee by day who has benefited tremendously from programs that ODEEP is modeled after. I am myself blind. Currently, people with disabilities are roughly 25 to 30% of this nation's population, but unlike the non-disabled workforce, have a roughly 50% unemployment rate. Blind and low vision individuals in America have an over 73% unemployment rate or underemployment rate. Most of them want to work, but are encountering systemic and attitudinal barriers to full and meaningful employment. This program will preserve and enhance the dignity of Marylanders with disabilities by creating opportunities for those individuals to work, including helping employers overcome those attitudinal barriers. We'll also get wonderfully talented people into the workforce or rising in the workforce, which will result in more contributions to taxes and less need for social service programs. A couple key examples of how this program would help: the provision of training for supervisors and staff to better understand the needs and capabilities of employees with disabilities, connecting the dots for applicants and prospective employees so that 100%, and that 40% can better match up in terms of what the Lieutenant Governor referenced, providing funding and support for assistive technology assessments, et cetera. ODEEP would be very different from DOORS because DOORS currently serves people who are either in job jeopardy or just starting in their career, and this can actually help with advancement for mid-level and higher-level professionals like me to shatter the glass ceilings. So it also doesn't take away from the services and supports for those with disabilities you've been hearing about via some of the activism of late. And I'm happy to answer questions about that should you choose to ask them. Thank you so much, and I urge a favorable report.
Good afternoon, Madam Chair, Mr. Vice Chair, members of the committee. I'm Rachel London, the Executive Director of the Maryland Developmental Disabilities Council and the Chair of the Developmental Disabilities Coalition. You have both of our written testimonies, and I would be remiss if I didn't say you've heard about the employment gaps for people with intellectual and developmental disabilities. It's actually closer to only 30% of those people working in Maryland. And policies and practices can and should change to make that number increase, so there are more people working. But I'm here today as an example of what does happen when an agency knows, understands, and accommodates a person with a disability. What you might not know is I've been living with multiple sclerosis for 16 years. In fact, I was sitting across the hall waiting to testify when I had my first MS flare. I had only been an employee with the DD Council for 6 months and a state employee only for 6 months. For the first 8 years, I got monthly infusions and only took 1 day off. I was doing really well, and then I wasn't. About 7 years ago, I needed a different kind of treatment, and I had to take a week off for daily infusions and then another week off to quarantine before that was a thing. And I had to do that 2 years in a row. Thankfully, our former director knew I could work remotely and keep working even while I was quarantined. And now, while I'm usually fine, I'm not always. Sometimes I'm slower. Sometimes I can't sit in front of a screen anymore. Sometimes my immune system is underperforming instead of overperforming, and I have to be away from other people. Accommodating all of those are things that can and should happen. This office would provide additional support to other state agencies and independent units of state government to work through those types of accommodations. Thank you.
Thank you, Rachel. Who's next?
Good afternoon, Chair Bidle and members of the committee. For the record, my name is Bong Del Rosario, and I serve as the Director of Transportation Policy for the Maryland Department of Disabilities. I want to highlight 2 parts of this legislation that directly connect my experience to state government. The first is that the State as a Model Employer, SAME for short, initiative will support active recruitment of people with disabilities to apply for state jobs. Back in 2019, I was working for a nonprofit, and I was told by a state employee that the Department of Disabilities was hiring, so I was encouraged to apply. It wasn't up until that conversation that I'd ever thought about or considered working for state government. In retrospect, it was probably because I didn't see anybody in state government that looked like me, so I didn't even really consider it. And that was a shame because, working now, I love it. The second part of the legislation that I want to highlight is that the same initiative will help, will help state agencies identify and remove unintentional barriers from recruiting and hiring with people with disabilities. So MDOD hired me for a role that involved traveling around the state. Often people assume if there's traveling involved for a job that you have to be able to drive. Well, I don't have my driver's license, and I use public transportation and paratransit to get around. As a matter of fact, that's how I got here today. So the fact that I use the system that I analyze for my job actually makes me better at my job. By nature, MDOD has always been hyper aware of the need to think outside of the box when hiring staff, and through the same initiative, the Office of Disability Employment can help support other state agencies in doing the same when it comes to hiring and accommodating new staff with disabilities. I respectfully request your favorable report for Senate Bill 433.
Perfect, thank you. English?
All right. Good afternoon, Chairman Beal and Beidle and members of the committee. For the record, my name is English Harper, and I'm currently working for Anne Arundel County government. However, I am here as a private citizen. I originally opted for an apprenticeship pathway after high school and was enjoying success at the top of my class until I was unfortunately involved in a life-altering car accident that had me facing a lengthy rehabilitation period. The injury left me unable to complete the apprenticeship, and without the college credits I would have received upon completion, essentially requiring me to start from scratch on my career. As a result of various programs and supports, peer mentorship, and connecting and networking with others in the disability community, I was able to find work, first with a nonprofit, and now with county government, where I was able to substitute experience for a college degree. Maryland state government's efforts to remove requirements such as college degrees for jobs and instead focus on experience and skill for many positions make them a potentially desirable employer for individuals such as myself. The Maryland as a Model Employer initiative created by this bill will continue to work to identify and remove barriers that inadvertently keep people like myself from obtaining state jobs. This program would offer me access and opportunities to advance my career in support of the state that supported me to become independent and financially self-sufficient after my accident. Thank you for this opportunity. I respectfully request your favorable report. Thank you.
Thank you, Mr. Harper. Do I have any questions for this panel? Seeing no questions, thank you all for your testimony. We appreciate you being here today. I have 3 more favorables. The last panel is Karen Lee, Matt Rice, and Melissa Rosenberg.
Hey, Karen, how are you?
You want to go first?
Sure.
It's right there.
Good afternoon, Chair Beidle, Mr. Vice Chair, honorable members of the Senate Finance Committee. My name is Matt Rice. I'm the Executive Director of People on the Go of Maryland, which is Maryland's statewide self-advocacy organization ran for and by those with intellectual and/or developmental disabilities. We have over 400 members statewide, and I will tell you that if those people are not working, they want to work. So we are here today to testify in strong support of SB 433, which would create the Office of Disability Employment Advancement and Policy under MDOD, which has been a leader for Maryland for many years. It's the only cabinet-level department of its kind, so it's appropriate that Maryland Department of Disabilities undertake this work. But as a person with a disability myself, this is very important to me. It took a very long time for me to find and obtain and retain employment. My hope is that under this initiative, we will give more people with disabilities the opportunity to not only have jobs that are more accessible and make the state more financially viable, because as we all know, we're in a deficit right now. So we need everybody that wants to work to be able to do that. We also want to show that Maryland is a leader and continues to recognize people with disabilities. We've done that when we eliminated subminimum wage, and we can do it again. And I hope for a favorable report.
Thank you, Matt. Who's next?
Hello. Hello, members of the committee. My name's Kiana Folk. I'm testifying in favor of SB 433 on behalf of the Autism Society of Maryland. 3 years ago, I participated in the autism hiring program created by the Autism Society. It connects highly skilled autistic job seekers like me with employers in a desirable career. The program provided me with job skills like interviewing, creating resumes and cover letters, and networking for future jobs. Fills a gap in Maryland's services to serve an untapped workforce of skilled autistic adults. Many have struggled to find and sustain employment. Candidates are high school graduates, many with college degrees like me, who do not receive support from DDA, DOORS, or an agency. At the same time, it connects employers to competent, capable employees like me, improving their bottom line while creating a more inclusive and neurodiverse work environment. It's through this program that I got my current job with a law firm in Towson, providing me with a higher salary and benefits, thus building my financial independence. I'm responsible for assisting lawyers with various tasks and making sure the office is well stocked and organized. Prior to my participation in the program, I worked at a warehouse and retail, hoping to move out my parents. But thanks to this opportunity, I was able to move in my own place with roommates and thus growing my independence. I'm still connected to the Autism Hiring Program team, where I can go to them if I have any questions or concerns about my job. Having the office will help workers like me who are often left behind while supporting employers like mine to hire them. And I hope for a fair report. Thank you for your time.
Thank you. And the last witness.
Hi. Thank you so much to Senator Chair Badal, Hay, and the entire committee, Finance Committee. Thank you so much for allowing us opportunity today to testify in support of Senate Bill 433. My name is Karen Lee. I'm the CEO of SEEK. We're a nonprofit organization in Montgomery County that provides employment support to people with intellectual and developmental disabilities. We support about 400 people every day out working, and their combined income is about $4.3 million. That's $4.3 million of taxable revenue for the work that they do. The Lieutenant Governor's story today is very touching to me. We're the organization that created the Project Church Partnership with Montgomery County and still to this day support Vineet. And he is really quite a guy. The opportunity for us to expand the work that we do, currently some with the federal government, some with our local government, and to include the state government would be just a tremendous opportunity to round out our relationship with the municipalities in the area. I want to share just a couple of really quick stories about some people whose lives have been impacted. And I won't share the story about Charles, who is the person that feeds through all of the MailChimp at NIH to make sure that wrong email addresses are corrected. But I will share that his employer is incredibly happy to not have to do that kind of work themselves, but Charles does that. I'll share the story about the police officers in Montgomery County who get up-to-date laptops and walkie-talkies and cell phones because of the work that Joey does. I'll share the story about the patients at NIH whose specimens get delivered to the exact correct labs all around NIH because of the work that Van does. So we support this bill and ask for your support of Senate Bill 433.
Thank you, Karen. Do I have any questions for anyone on this panel? Seeing no questions, I want to thank you all for your work. Thank you for your testimony. That ends the hearing on Senate Bill 433. We now have with us Senator Augustine, Senate Bill 684, Public Health and Health Equity. He's our honorary 12th member of the committee.
Thank you, Chair Bidel.
Senator, you do not have a panel for Senate Bill 684, correct? Public health and
That's
health
correct.
equity.
Thank you, Madam Chair, Madam Vice Chair, members of the committee. Senator Malcolm Augustine here on behalf of Senate Bill 684, Public Health Equity Dashboard. Basically, as you all know, we have significant disparities in health, and we also know that it particularly now, given what's sort of happening at the federal level, it's very important for us to keep up with information at the state level. And that's what this health equity dashboard does. I would direct you to a letter from the Department of Health, because this is internal information that the Department of Health is able to collect and to do. They've offered a letter of support with amendments. The amendment just changes the frequency with which the dashboard would be updated. We had in the bill originally 30 days. We kind of came to an agreement that it made sense for it to be refreshed on a quarterly basis as the data were made available. It is a Black Caucus priority bill, and with that, I would ask for a favorable report on Senate Bill 684, incorporating the Maryland Department of Health amendments. Thank you.
Thank you, Senator. And you have submitted the amendment, correct?
No, but I'll send it in. But that
Oh, you have
MDH
it.
did.
Thank you. We have that. Thank you, Senator. Any questions for Senator Augustine on Senate Bill 684? All right, that ends the hearing on 684. Next, we have Senate Bill 589, Opioid Restitution Fund Interactive Dashboard. Again, we have Senator Augustine, Kristen Pendergrass, and Ann Seacott.
Thank you. Thank you, Madam Chair, Mr. Vice Chair, members of the committee. Senator Malcolm Augustine here on behalf of Senate Bill 589. This is the Opioid Restitution Fund Interactive Dashboard. Colleagues, it's a similar sort of situation where there's even more urgency on us making sure that we maintain and keep information available as far as how we are managing our various health situations, including the opioid and crisis that we still have. So the department has been working on, I know this committee is aware of their dashboard that already deals with the outcome side of things, which is very important. There's just no question about that. We know that it's very important. What this seeks to do is to incorporate the how the settlement money that is out there for the opioid restitution fund, let's overlay that and make it an interactive dashboard where they will be able to work together. What we have heard in this instance is that the department is able the funding for this really comes out of Maryland Office of Overdose Response. And so they're able to do this. We can make this happen. There has been a request for an amendment from MACO as it relates to some of the way that the information is moved. And the first one, there is kind of agreement on it that we would, instead of requiring the information, that we would create a link to the state and county or municipal websites. So we're good with that. There's a second part that I think there's still a little bit of work for us to do on going the other direction, on where we compile the information and the state required to send it back out. So that part there, I think, is still a little bit of work, but for the most part, I think we've come to a place of agreement, managed to make this something that could work, and again, to help us to get a better picture of the concerns, but then how we're using the funds that we have in order to address the crisis that we're having. With that, I will ask for a favorable report with amendments and pass it to the panel.
Kristen or Ann, who's next?
That's me. Thank you, Madam Chair, members of the committee. My name is Kristen Pendergrass. I'm the Vice President of State Policy for Shatterproof. We are a national nonprofit dedicated to ending the addiction crisis through ending addiction stigma, increasing access to treatment, and improving public policy. Much of the policy work that I do around the country is related to opioid settlement funds and ensuring good governance. I lead a national coalition of about 30 organizations that are also working to this end to make sure that settlement funds are being used to their highest, best use. And we were an early endorser of the Johns Hopkins University Principles for the Use of Funds from the Opioid Litigation, which is a set of 5 principles to guide state and local governments to maximize the impact of opioid settlement funds. The 5th principle of the 5 encourages jurisdictions to develop a fair and transparent process for deciding where to spend the money. And we believe that Senate Bill 589 builds on the great work already done by Maryland to increase transparency and accountability as it relates to opioid settlement funds. In the 3 years that I've been doing this work, the question that I get most often around the country is, where is the funding going and who is tracking it? So about a year and a half ago, Shatterproof partnered with Johns Hopkins University and KFF Health News to track the funds around the country. We compiled all public reports to states and by states. And of the $6 billion received in 2022 and 2023, this is nationwide, about a third of that, or $2 billion, is unknown. We're unable to account for it. We don't know if it's been spent or where it's been spent. In Maryland, we know that in those 2 years, 2022 and 2023, $95 million was received, but more than $29 million of that is unknown. And much of that is municipal spending, where we just don't have any public reporting about where that money is going. Again, Senate Bill 589 would help to rectify this. 2 more points I want to make. Shatterproof often hears from people who have been directly impacted by the opioid crisis. They've either lost someone or they're in recovery themselves, and they want to know how the money's being spent and have an opportunity to weigh in. Senate Bill 589 requires the dashboard to include information on public hearings, which would allow people greater access to those public hearings to have their voice heard. And the bill also asks that municipalities report performance measures where applicable, and we believe that this would really help the state as a whole monitor the progress and the impact that opioid settlement funds are having around the country and in Maryland. So I just wanted to thank you and commend you all for the work that you're doing to make sure that opioid settlement funds are being spent wisely.
Thank you. And Ann, you want to?
Thank you. Thank you, Madam Chair, Mr. Vice Chair, members of the committee. I'm Ann Seacott, testifying today on behalf of the Maryland chapter of the National Council on Alcoholism and Drug Dependence, in strong favor of Senate Bill 589. This bill is about transparency. This is about accountability. The state and all the states across the nation have decided to hold the opioid manufacturers responsible, accountable for what they've done. And now we need to make sure that we are being holding accountable all of the local and state government for what they are, how they are spending those dollars. We think this is very important. You all passed legislation last session that considered something similar to this, and the result of that legislation was a report by the department that did include this as an example of the potential ways to track the dollars. So we understand that local governments don't want additional reporting burdens, and we do not want to overburden county or municipal governments. At the same time, we think it's really important that the money that they are spending be reported, and so, you know, adding the state to the email where they're sending in data, we think is a very fair thing to do so that everything is available to the public for proper scrutiny. So with that, we ask for a favorable report.
Thank you, Ann. Do you have any questions for this panel? Senator Reedy?
Thank you very much, Madam Chair. I guess I could probably address Ann with a question. It's accurate to say taxpayers expended a tremendous amount, a good bit of money in legal fees to extract these dollars, correct? So this is not only did obviously all of our citizens bear the brunt of this terrible epidemic, but also when we talk about putting requirements on governments that get this money to at least let us know what they're doing with it, and many do, but sure, we don't always have comprehensive data. So this is just an opportunity, right, to recoup. It's fair to say we expended a good bit of taxpayer dollars to obtain these dollars.
Absolutely. Taxpayers have paid to get it, and the taxpayers have paid with the consequences of the overdose crisis as well. So, and as you know, obviously we are the government, right? So it's our tax dollars, it's the government's spending all this money. Right. Absolutely.
Okay, thank you. Thank you, Madam Chair.
Thank you, Senator. Any other questions for this panel? Seeing no questions, that ends this panel. You have one favor with amendment. Sarah Stample's here from NACO.
Thank you to the chair, members of the committee for having me today. My name is Sarah Sample. I'm here on behalf of the Maryland
Sarah,
Association.
will you pull your microphone a little closer,
Yep.
please?
All right, thank you for having me today. My name is Sarah Sample. I'm here on behalf of the Maryland Association of Counties, and we support with amendment Senate Bill 589. We absolutely agree that the dashboard is an important thing. Transparency is going to encourage public trust, and that's what we want. We did submit a few amendments. Like you've heard, we have spoken with the sponsor. The first amendment about the hearing, or about having the link on the website, they're comfortable with that one. I can just go ahead and describe the other two amendments that we were hoping for. They are also in the written testimony. The second one is just that when we hand off the information to the state, we would like it for it to be their responsibility to go ahead and make that information public. So that way we handle reporting on our end, and they handle making things public on their end. The other thing is just really some language clarifying that the standard for which we are in compliance with the settlement agreements, but also the requirements from the state. So those are the only other two things that we wanted to just make sure that we were clarifying, and also just certify that we're not duplicating efforts, because we want to make sure that we're spending time remediating rather than being arrested by more procedure. And the last thing I would add is that there's no way for us to get around not reporting. Even money that goes directly to the local jurisdictions has to be audited by the state. So we have standards that we have to comply with, and certain reports that we have to submit for all of that funding. So we're happy to comply. We just want to make sure the process isn't too onerous. But so we're support with amendments for those reasons, and we would urge a favorable report with those amendments. Thank you.
Sarah, thank you for your testimony. I don't see any questions, but I know you'll continue to work with the sponsor and we'll get those amendments. Thank you.
Thank you.
That ends the hearing on Senate Bill 589. Senator Augustine, one more time. Senate Bill 592, Public Healthcare Quality Fund for Community-Based Behavioral Health Programs. We also have with us Senator Hedelman, who's here from B&T.
Oh, yeah.
Welcome, Senator. And your panel's Nicole Granner, Dan Shattuck, and Sarah Sample.
Yep.
Thank you.
All right. Thank you, Madam Chair, Vice Chair, members of the committee. Senator Malcolm Augustine here on behalf of Senate Bill 592, Public Healthcare Quality Fund for Community-Based Behavioral Health Programs Establishment. Colleagues, Maryland's facing a critical behavioral health workforce shortage, as you well know, and according to a recent report from the Maryland Healthcare Commission, we have only half the workforce needed to address our demand. The shortage results in service delays, increased provider burnout, and inability to meet needs of our most vulnerable residents. Meanwhile, there is not so much transparency regarding how existing penalties in this sector are enforced, or where those funds are allocated, and that's what this bill seeks to do. We have the partnership of the people who are actually subject to that. They want to make sure that they are being held accountable. But what the bill does, though, is it makes sure that when we do that, if those penalties do come apart, we want to make sure that they then are reinvested where they came from, back into making sure that we're doing well within our community-based behavioral health programs. So what this bill will do is it will create a dedicated non-lapsing fund to reinvest civil monetary penalties into workforce training programs, grants, other quality improvement initiatives. Will ensure that the penalty funds remain with the behavioral health system, preventing reallocation to unrelated state expenditures and guaranteeing transparency. The bill follows Maryland's existing approach to the assisted living facilities and nursing homes and aligns with penalty structures used in other health sectors, including housing and other areas. Like I said, the penalties, some of the structure of it, really are in keeping with what we've done at the nursing homes and the assisted livings. It's sort of a similarly situated. And it caps penalties at $10,000 per instance of violation and aligns with civil monetary penalty standards in those nursing homes and the residential treatment centers. This model is also already happening in other states. Rhode Island, Connecticut, Pennsylvania successfully use similar funds for mental health and opioid response programs. And then at the federal level, the Center for Medicaid and Medicare Services has seen positive health outcomes by reinvesting civil monetary penalties into those nursing home improvements. And we do have these things in Maryland. And it is the charge of the department, Behavioral Health Administration, to build the infrastructure. They're doing it anyway. They're building the infrastructure in order to be able to institute these penalties, do a better job of doing just that. One thing that the department did ask for, and it makes all the sense in the world to me, is in the original, the way that the bill is written, it includes the Office of Healthcare Quality, and that was done because that's the way that the ALF / nursing home, one that we already have here in the state, is set up. But the department came back and said, hey, listen, this is all within the Behavioral Health Administration. All it will be there. And so the ask is just to strike. It's all it requires is just to strike the AHQ information. And from that, I'll just ask for a favorable report as with that amendment. And I'll turn it over to the panel. Happy to answer any questions. Oh, go ahead.
Good afternoon, Chair Bidle, Vice Chair Hayes, and members of the Finance Committee. My name is Nicole Grainer, and I'm the Director of Government Affairs and Public Policy with the Community Behavioral Health Association of Maryland, here to express our strong support for Senate Bill 592 as amended. As the leading voice for community-based providers in Maryland, CBH represents 87 organizations serving the majority of individuals accessing care through the state's public behavioral health system. These providers deliver essential mental health and addiction services, including outpatient and residential treatment, case management, and crisis intervention. As you've heard, our sector is grappling with severe workforce shortages, which have resulted in service delays, increased staff caseloads, and diminished capacity to meet the growing demand for care. Senate Bill 592 offers a proactive solution by ensuring that civil monetary penalties, or CMPs, imposed on behavioral health providers are reinvested into workforce development and quality improvement initiatives. This reinvestment will directly support training programs, recruitment efforts, and staff retention, allowing providers to stabilize their workforce and enhance the quality of services that they provide to vulnerable Marylanders. Importantly, the bill ensures that CMP funds are used transparently and effectively, targeting workforce development and compliance with state regulations, while avoiding excessive financial burdens on providers. By capping fines and dedicating the funds to a healthcare quality fund, this legislation fosters continuous improvement within the behavioral health system. Senate Bill 592 will help strengthen Maryland's behavioral health workforce, improve service delivery, and increase access to care. We believe this approach is essential to addressing the workforce crisis and improving patient outcomes. We respectfully urge a favorable report on Senate Bill 592. Thank you.
Thank you, Nicole. Dan?
Thank you to the chair and members of the committee for having me. Again, my name is Sarah Sample, here on behalf of the Maryland Association of Counties, and we support Senate Bill 592. This is, as you've already heard, dedicated funding for community behavioral health programs. It can add resources for training, grants, and other projects, and so we think that is amazing. This is just another tool in the toolbox, and there is obviously great need, and we think the senator is very wise for recognizing that and putting this bill in. So we're happy to support Senate Bill 592. Thank you.
Madam Chair, members of the committee, my name is Dan Shattuck, here today on behalf of the Maryland Psychological Association, also in strong support of this bill. I think it's been laid out pretty clearly, and the word that resonates is reinvestment. It's really keeping the funds within the same sphere. If it comes on the back of, programs that have to pay fines or penalties, at least the money is coming back into for the same purpose, really. So, and as the senator pointed out, this is a model that exists elsewhere, so we're not creating anything new. We're just going to try and implement it here in the state of Maryland. And for that, we ask for a favorable report.
Thank you, Dan. Do I have any questions for the senator or for this panel? I don't see any questions. Thank you very much. Senator Augustine, it was nice to see you today. Thanks for spending your time with us.
Madam Chair. All right.
Senator Hellerman?
And Mr. Vice Chair.
Senator Hellerman, Senate Bill 674, Maryland Commission for Women, Maryland Collaborative to Advance Implementation of Coverage of Over-the-Counter Birth Control. And you have with you Senator Ariana Kelly, Jakaya Johnson, and Robin Elliott.
Thank you very much. Madam Chair, Mr. Vice Chair, members of the Finance Committee, I am very happy to be here with you today to present Senate Bill 674, which is called Maryland Commission for Women, Maryland Collaborative to Advance Coverage of Over-the-Counter Birth Control. I'm going to tell a little story. When shortly after I was elected, I think like many of you, people ask you, what is the biggest surprise to you becoming an elected official? And I have to say, after some time, and this is still my answer 11 years later, is how much work you have to do once your bill gets passed, right? It's hard enough to get a bill passed. And then you have to keep on it and make sure that it is implemented the way that you envisioned. This bill addresses that very issue. So the wonderful new director of the Maryland Commission for Women. It was our former colleague here for 10 minutes, has spent much, much longer time in the House, but made tremendous contributions on the issue of reproductive health. And one of the bills that she introduced back in 2016, along with Senator Dolores Kelly, was to expand access to contraception. Unfortunately, since that time, there's been a lot of things that have happened in that area, but the point of that bill has not been fully realized, and that is why we are here before you today with this bill. So this bill creates a collaborative with state agencies, consumer representatives, pharmacies and pharmacists, and insurers to support implementation of that 2016 bill. We have been through a lot on these issues over the past number of years. And here in this country, the FDA approved 2 different forms of birth control for over-the-counter use. Plan B, which is emergency contraception, that was approved in 2006, and Opill, a daily birth control pill, in 2023. And over-the-counter birth control is supported by many major medical organizations. It is safe, it is effective, and there's a lineup of very prominent medical organizations that fully back its use. It can significantly increase access because people don't have to navigate going to the pharmacy, getting a prescription from their physician, and then having to do all the steps that we all have to do for various and sundry medications that many of us take, which is a hassle. Important provisions, but again, by doing it this way, over the counter, can be done safely and more accessibly. There is also the issue of affordability. Over-the-counter birth control costs a fair amount, and insurance coverage is important to ensure the affordability of it. And really, that was the point of the bill in 2016, is to make sure that people could have access to birth control without the cost sharing. In 2018, Senator Kelly and I followed up on the bill that the other Senator Kelly had introduced in 2016 and extended over-the-counter requirements to state employees and retirement benefits plans. Lots of other states also took our lead and enacted legislation of their own. In this past October, the U.S. Department of Health and Human Services also proposed regs to require that nearly all insurance plans across the country cover over-the-counter birth control. Unfortunately, those plans were withdrawn with the new administration in January 2025. Which brings us back to Maryland. We need to dive into what we did in 2016 and make sure the provisions of that law are being fully implemented. We need to work with the insurance companies to make sure their plan documents correctly reflect over-the-counter birth control coverage. We need to advocate and clearly communicate with pharmacies. Back in 2019, I was actually contacted by an individual who couldn't access her coverage of state coverage for over-the-counter birth control, and we worked with DBM on this, and as a result, and I think it's in your packet, CVS issued a clarification to talk about how pharmacies should process over-the-counter birth control claims. So those are a couple of the very important, the insurance issues and the communication and collaboration with pharmacies that need to happen. In this past fall, I asked DBM, because I was curious about it, how many people had actually made claims under the state coverage for over-the-counter emergency contraception, and learned that in an almost 2-year period, only 139 claims had been made, and only 4 claims for Opill, the new daily birth control pill, during an 8-month period. That is not, we know that there is pretty prolific use of birth control. Those numbers seemed awfully, awfully low to me. So what does this bill do? This bill focuses on pharmacies, on the development of clear and consistent communication with them on how they can submit claims for over-the-counter birth control. It also focuses on marketing, how to increase awareness among consumers, pharmacies, pharmacists, healthcare providers about over-the-counter birth control, and it works to focus and develop avenues for communication and work with community-based partners to provide over-the-counter birth control to people without insurance coverage. This is a collaborative that brings together all these different community stakeholders and will make a series of recommendations in a pretty quick fashion and will be staffed by the Maryland Commission for Women. So that is, in a nutshell, what the bill does, what the problem is, and what the bill does, and how it addresses it. And without further ado, I'm happy to answer questions or turn it over to my panel, whichever you like. Thank you.
I don't see questions, so we'll turn over to your panel. Senator Kelly, once a senator, always a senator. It's nice to have you back.
Thank you so much, Madam Chair. It's lovely to be here. Thank you so much for having us. Thank you to Senator Hettleman for putting this legislation in and coming to the Commission for Women with this idea. So great to be here and back among you all. This legislation builds upon the work that this committee has done. As Senator Hettleman mentioned, both she and former chair of this committee, Dolores Kelly, were real leaders in ensuring that Marylanders have access to insurance coverage for over-the-counter birth control. What the Maryland Commission for Women would do with this legislation is convene the collaborative over a 2-year period, provide an interim report and a final report. We at the Maryland Commission for Women, when I left this esteemed body to join the Maryland Commission for Women, I heard from more than one colleague, we have a Maryland Commission for Women. What do you do? So I will give you a quick refresher. We were established by the legislature, specifically the women legislators of Maryland, back in 1971. We were established in order to identify problems facing Maryland women and propose effective solutions both to the legislative and executive branch. So this proposal that's before you really fits well within our statutory authority, and we were so excited to look at it because what it does is it has us convene the collaborative. And again, if you look in the statute from 1971, we're authorized to convene advisory committees on issues, especially women's health issues, and work in partnership with state agencies and community groups. So that's what we need done here. Senator Hettleman did a great job of laying out the problem you are all well aware of, which is sometimes the bills pass and we need a little bit more work getting it fully implemented. It's a very exciting time for over-the-counter birth control access, and you'll hear more about that from the rest of the panel. I'm here just to thank Senator Hettleman as well as Chair Pena-Melnick for this proposal and make sure all of you know that the 25 commissioners who are members of the Maryland Commission for Women voted unanimously to support this and integrate this, should the legislature pass this, integrate it into our 3-year plan. We can do it with existing resources. Thank you so much.
Thank you. Who'd like to go next? Thank you.
Thank you. Good afternoon, Madam Chair, Mr. Vice Chair, members of the committee. My name is Jakia Johnson, and I'm the Executive Director of Reproductive Justice Maryland, and I appreciate the opportunity to be here today in strong support of Senate Bill 674, which seeks to establish the Maryland Collaborative to advance implementation of coverage of over-the-counter birth control. That's a mouthful. Access to birth control is a fundamental aspect of reproductive freedom and autonomy, as we all know. And this bill is a very important step toward true accessibility and equity in contraceptive care for all Marylanders. The Contraceptive Equity Act of 2016 made Maryland a leader in coverage of OTC contraception, but as we've all seen, coverage alone does not guarantee access. We know that significant barriers remain, and especially for our marginalized communities, for young people, and those experiencing economic hardship. The ability to get birth control without unnecessary delays or financial burdens directly impacts a person's ability to plan their future, pursue education, pursue their career goals, and maintain their own personal well-being. Unfortunately, many Marylanders are still not aware of their right to covered over-the-counter contraception, and our pharmacies and insurers lack clear implementation guidance, leading to very inconsistent and inequitable access across the state. The bill would ensure that access to over-the-counter birth control is not just a theoretical right, but a lived reality for all Marylanders, and the collaborative will work and engage with community organizations, health experts, retailers, and insurers to develop solutions that work for real people in real time. And for those reasons, Reproductive Justice Maryland strongly supports Senate Bill 674 and urges a favorable report to uphold Maryland's commitment to equitable reproductive health access. Thank you for your time.
Thank you. Robin Elliott.
Good afternoon. Robin Elliott. Today I am representing Reproductive Justice Maryland. I work very closely with Jakia in full support of the bill. I just wanted to add a couple of different points. First, Maryland was the first state to enact over-the-counter contraceptive coverage requirements, which is very exciting. Today, 10 states, so 9 others following Maryland, have over-the-counter coverage on the books. There has been lots of effort on the national level to support implementation. In fact, there was a collaborative run by an organization called IBIS Reproductive Health, whom you're going to hear from virtually, that pulled together a group of stakeholders very similar to what this bill proposes to look at what could be done to implement over-the-counter coverage. There's a wonderful report. It's referenced in the bill. So the great thing is that the collaborative here in Maryland would not have to start from scratch. It can build its work on the work that has been done nationally, as well as work with our colleagues from other states, and you may hear from some of those other states as well. They're very practical solutions to making over-the-counter coverage work of birth control or any other coverage of over-the-counter medication. It has to do with just making sure pharmacists know how to bill, making sure consumers know that they have that coverage. It could be as simple as a webinar by a board of pharmacy, a bulletin from an insurance administration, all very practical solutions. And so it is really, really promising that this collaborative proposed in this bill could actually make coverage work here in Maryland, and we could be the first state to make it happen. Thank you very much.
Thank you, Robin. Do you have any questions for this panel? Seeing no questions, thank you very much. We have one more favorable in person and then one virtually. So Kelly Locklear.
Good afternoon, Madam Chair and honorable members of the Senate Finance Committee. For the record, Kaylee Locklear here on behalf of the Maryland Association of Chain Drug Stores. We are here in full support of this legislation. We had a really productive meeting on the House side with the cross-file advocates and have had discussions with Senator Hettleman's office as well. We really think it makes sense to study this and make recommendations. Our continuing challenge on the pharmacy side, won't come as a surprise, we talk about it all the time, is reimbursement for our services. And then marketing this truly so that consumers understand not only can we prescribe birth control, but also have over-the-counter and can provide services and advice to them in reference to that. So we thank the sponsor and the commission for specifically including us as representatives in the collaborative, and we look forward to making recommendations to the committee. So with that, we urge a favorable report. Thank you so much.
Thank you, Kelly. I don't see any questions. Thank you for your testimony.
Thank you.
We have one virtual, Bria Good for information. Bria, unmute and you can start.
Good afternoon, Madam Chair, Vice Chair, and members of the committee. My name is Bria Good, and I serve as the Senior Policy, Advocacy, and Research Manager for Free the Pill, a project of IBIS Reproductive Health dedicated to expanding access to and coverage of over-the-counter birth control. As a proud Maryland native, born and raised in Prince George's County, and a graduate of the University of Maryland College Park, I am pleased to be able to provide information on OTC birth control for the committee to consider on Senate Bill 674. Maryland has long been a leader in increasing access to over-the-counter birth control, from becoming the first state to mandate insurance coverage of OTC contraceptives in 2016 to requiring college campuses to provide access to contraceptive hours. However, despite these groundbreaking policies, barriers to implementation continue to limit the real-world impact. Insurance coverage for OTC birth control remains inconsistent, creating unnecessary challenges for Marylanders seeking essential reproductive health care. As we know, policy alone does not guarantee access. Coverage is only meaningful if it works in practice. Senate Bill 674 is a critical step toward bridging the gap. By ensuring that coverage is implemented effectively and equitably, this bill will make it easier for Marylanders to access birth control when and where they need it. establishing an implementation collaborative that brings together key stakeholders, including pharmacists, insurance commissioners, reproductive justice advocates, public health officials, and researchers, will help develop practical solutions to address coverage barriers and educate the public on their options, as well as ensure seamless access to contraception at pharmacies and other points of sale. This bill is about making sure that no Marylander is left behind. Maryland has set the standard for expanding access to over-the-counter birth control, and passing Bill 674 will ensure the state remains at the forefront of this movement. This legislation will not only solidify Maryland's leadership, but also help transform policy into meaningful, equitable access, breaking down systematic barriers and advancing reproductive justice and autonomy for all. Thank you for your time.
Thank you, Bria. Thank you for your testimony. I don't see any questions for this witness. Thank you. That ends the hearing on Senate Bill 674. Thank you. My vice chair is going to take.
Now, we're going to hear from Senate Bill 696, with the sponsor being Chair Beidel. On her panel, she has a lot of people. We're going to start and fill up as many seats as possible with David Stockwell, Maria Manna, Dr. Jennifer Dorr, and Carrie Elthridge.
Good afternoon, Vice Chair Hayes and members of the committee. For the record, I'm Pam Beidel. I'm presenting Senate Bill 696, Public Health Pediatric Hospital Overstay for Patients. I'm pleased to present this bill. Pediatric hospital overstay addresses an egregious problem impacting children and youth across the state. For many of you know, you've heard reports from the ED wait times, and one of the issues with ED wait times is that we don't have placement for some of the pediatric patients that come into the ED. Many of these children have emotional behavioral problems, and there just is not placement available for them. So when youth are stuck in the emergency room and unable to transition to a more appropriate care setting to meet their needs, this negatively impacts the child, the hospital staff, and members of the community who need access to emergency services. You'll see some testimony that has children staying in the emergency department for like 6 weeks. We had one case where a child was 100 days. It's not good for the children, it's not good for the ED, and it's not good for all our constituents that are waiting to get into the ED because we're losing about 25% of the beds. While Senate Bill 696 will not solve all our problems, this legislation takes concrete steps to expand the behavioral health capacity we need in the short term and bring oversight and accountability for placing these youth in appropriate setting. The bill does the following. It expands residential treatment capacity by directing MDH to staff the licensed but unstaffed state-operated residential treatment beds. There are currently 17 of these beds in the state, and expanding capacity even by this much will make a difference. MDH can use funds currently designated for the Adolescent Hospital Overstay Program to accomplish this. Requires state hospitals to participate in the Maryland Mental Health and Substance Use Disorder Registry. Right now, there is not a line of sight into how many open state beds we have, but we have the private hospital side. This level of transparency will help us better understand bed capacity across the state. Next, it establishes a pediatric hospital overstay coordinator within the Governor's Office for Children to advocate on behalf of the children stuck in hospitals and streamline placement efforts. This single point of contact will coordinate with hospitals and all relevant state agencies in pursuit of the most appropriate placement option. The coordinator is also required to report annually to the governor and the General Assembly on the status of pediatric overstay patients across the state, including recommended policy and procedures. And lastly, the bill requires the Department of Health to review the reimbursement rates paid to residential treatment centers and respite care facilities for potential reforms that will incentivize the expansion of RTC and respite care facility capacity in the state. We did not get into this problem overnight, and we will not get out of it overnight. However, passing this bill will allow us to take immediate action to address the needs of children and youth stuck in hospitals across the state. Thank you for the opportunity to present this legislation to the committee. and I respectfully request a favorable report on Senate Bill 696. Thank you, Mr. Vice Chair.
Thank you, Madam Chair. David?
Mr. Mind if I kick things off? Is that right? Ryan? Thanks so much. Thank you, Mr. Vice Chair, Madam Chair, members of the committee. For the record, my name is Andrew Nicholas, representing the Maryland Hospital Association. First, I want to thank the chair for sponsoring this very important bill and for her continued support in helping us address this very challenging issue of children being stuck in hospitals across our state. So to be clear, these are children who've come to the hospital with some acute issue, either behavioral, physical, or some combination thereof. They have received treatment, they have been stabilized, and they have been medically cleared for discharge. There's no longer any reason for them to remain in the hospital except for the fact that there's no other place for them to go. Either there's no one available to pick them up or willing to pick them up and take them home, or there's no available space at a lower level of care facility. So MHA has been collecting data from our members on this for the last 8 weeks, and currently in Maryland we have 43 children in overstay status, and nearly 20% of those are in emergency departments. There are about 19 are involved with the Department of Human Services or local social services agencies. About 30 are waiting for placement in residential treatment facilities. And on average, these kids are spending 31 days in the hospital after being medically cleared for discharge. So MHA supports this bill because it presents a practical, measured, and yet still impactful approach to helping alleviate this problem. As the chair pointed out, this is not a silver bullet. This will not fix everything, but it will provide some immediate relief for these kids and hopefully lay the groundwork for further reform in the future. And so for all of those reasons, we urge a favorable report on the bill, and I'm happy to answer any questions at the end.
Thank you. Is David on the panel? Is that you, David? Okay. David, you want to go ahead and proceed with your testimony?
You want to have, go ahead. You want Dr. Scarl, David?
Sure. Good afternoon, Mr. Vice Chair and members of the committee. My name is David Stockwell. I'm the Chief Medical Officer of the Johns Hopkins Children's Center. I'm here to express Johns Hopkins' strong support of SB 696. You will hear from other members of the panel and the hospital community about the impacts of hospital stays. We experience this impact as well. I want to talk about the impact on hospital operations. In 2024, we had 1,591 days of boarding, of which 65% were children waiting DSS placement. This took 3 to 5 of our beds offline for use by medical, surgical, and psychiatric patients for the entire year, which led to 218 admission denials because we are always at full capacity. Of these 218, 39 required ICU level care, the kids that were denied, and were urgently transported to facilities out of state. JHCC is the only pediatric level 1 trauma and burn center in Maryland and the only ECMO center in Maryland, which is the highest level of care. Any denial to JHCC could place a child in imminent danger, and certainly it delays their treatment. From a staff perspective, our social workers spend an average of 6 hours per child per week on care coordination. Each child typically has a one-to-one staff supervision, a separate security detail, and high levels of nursing engagement, all tremendously valuable hospital resources. Lastly, some of these children have destroyed medical rooms, taking them offline for weeks after they leave. Our top priority is the safety and well-being of children, but these hospital operation issues are important, as I know the committee deals with legislation on ED wait times, workplace violence, and the healthcare workforce shortage, all of which would be helped by passing this legislation. We have failed these children. It is the legislature's opportunity to create some accountability and investment in helping them. For these reasons, I urge a favorable report of SB 696.
Maria Manna, thank you for your testimony.
Good afternoon, Chair, Vice Chair, and committee members. My name is Maria Manna. I'm a registered nurse, and I'm the Director of Care Management for Northwest Hospital, a LifeBridge Health facility. I'm here today in support of the Senate Bill 696 and to talk about some of the challenges that we face at Northwest Hospital related to boarding adolescents in our emergency department on a routine basis. Northwest Hospital on any given day has 2 to 4 adolescents boarding in the emergency room, and while that doesn't sound staggering, the length of stay is. We have currently 2 adolescent females, 36 days, 21 days, and more recently discharged a patient 90 days in duration in our emergency room waiting for an inpatient acute psychiatric bed. Having said that, the processes that we have to avail ourselves to place these patients are complicated, cumbersome, and tedious. We utilize all of the available resources such as 211, Department of Social Services, DDA, BHA. As you can see, it sounds like alphabet soup, and that's pretty much the way they operate. Interacting with these agencies, I can tell you there's a lack of urgency with them, while the hospital faces the need to move these patients to an appropriate placement. The patients are kept in an emergency room where the structure is very limited, and in fact, they are in the presence of other adults that require inpatient hospitalizations as well. It is not ideal, it's not conducive to their behavioral health needs, and it is, in some instances, can be further traumatic. It would challenge even those of us who have wonderful frustration tolerance. I would encourage the support of this bill to streamline the processes of the various agencies and the identified coordination groups that serve us. Thank you.
Thank you for your testimony. Dr. Jennifer Dorr.
All right. Hear me? Okay. Chair Vital, Vice Chair Hayes, and members of the committee, thank you for the opportunity to provide testimony in favor of Senate Bill 696. My name is Dr. Jennifer Dorr, and I'm a child and adolescent psychiatrist at Children's National Hospital, which we have about 60% of patients there who are Maryland residents. I'm speaking on behalf of Children's National, the Maryland Psychiatric Society, as well as the Washington Psychiatric Society. Senate Bill 696 aims to have pediatric patients admitted to the least restrictive environment appropriate for their clinical needs. This bill has a strong aim and is very important to the quality of life of our pediatric patients. Being on the front lines, I see what devastation can be caused if a child is unable to be discharged from inpatient care when they are stabilized. While working on the inpatient unit, I encountered a patient we will call Joe. Joe is a 14-year-old individual who had PTSD from significant abuse as a younger child and a genetic syndrome. He was stabilized after a few weeks inpatient. However, Joe remained on the psychiatric unit for over 5 months, awaiting placement. This not only took a bed from someone else and was a huge cost to the system, but this also greatly affected the patient's overall mental health. When a child is stabilized but must stay in the hospital for months, it is a serious issue and may halt social, emotional, educational, and developmental growth, and can actually worsen a patient's mental health. They feel trapped because essentially they are trapped. A hospital or an inpatient unit is not an appropriate place for a child to grow up. We need to do better for the children of our nation and especially of our state. I have many other examples of such patients. Quite frankly, our system is failing our children. Please help us as child and adolescent psychiatrists help our patients and families. Let's stop punishing families and children who come to the hospital for help. I applaud Chair Beidel for introducing this important legislation, which will have lifelong benefits for our state's youngest residents. I respectfully request a favorable report on SB 696. Thank you.
Thank you for your testimony. Carrie Elthridge.
Madam Chair, Mr. Vice Chair, and members of the Senate Finance Committee, thank you for the opportunity to testify on this critical bill. I also thank the Chair for recognizing its importance. My name is Carrie Etheridge. I'm the Director of Social Work at Sheppard Pratt. I'm here to share my firsthand experience in hospital, inpatient psychiatric, and residential treatment center processes to highlight the challenges that our pediatric patients and care providers face daily. Our acute settings are meant to stabilize and get patients to a less restrictive setting, such as day hospitals, outpatient therapy, or RTCs. A locked inpatient psychiatric unit is meant to be brief, not months, and sometimes years, simply because they have nowhere to live. Children miss critical education and social development opportunities when confined to a hospital setting, While home and hospital is utilized, it does not remotely meet the needs or expectations of a full academic day, occurring a few hours a week at best, depending on tutors' availability and schedules. Being hospitalized for extended periods can be re-traumatizing, leading to worsening mental health conditions. Knowing you're abandoned and no one is coming to pick you up, whether that is your family or your DSS worker, is incredibly demoralizing for a teen who has already been abandoned by so many parts of the community and our system. Watching other kids come and go, families visit and pick up their peers is incredibly destabilizing. The burdensome process in place that are ineffective, time-consuming, and broken exacerbate these issues. Waiting for the VPA process, CPS and DSS to reply to abandonment reports, waiting for group homes and RTCs to have the staffing, even if a bed is available, and absolutely no recourse or consequence for families that refuse to pick up their children, such as an automatic SINA hearing, adds to the delays and travesty that these children face. Placements are lost because of red tape and ill-created state systems that don't talk to each other and don't meet the needs of Maryland's most vulnerable. We are in full support of Bill SB 696. Thank you.
Katrina Escuro.
Good afternoon, Mr. Vice Chair and members of the committee. My name is Katrina Escuro, and I'm a child and adolescent psychiatrist at the University of Maryland Medical Center in Baltimore. I've been treating children and adolescents for the past 9 years, and I currently serve as a medical director for the Child and Adolescent Psychiatry Inpatient Unit. Thank you to Madam Chair for bringing this bill forward and offering steps towards increasing both the capacity and accessibility of our current behavioral health system. I am here today in strong support for Senate Bill 696. In psychiatry, an inpatient unit is the highest, most restrictive level of care, similar to an intensive care unit in other areas of medicine. Once someone is stabilized, they need to step down to a less restrictive setting to continue their recovery. A typical length of stay on our unit is maybe 1 to 2 weeks. During my first year of training, I treated one 10-year-old child who remained on the unit for 4 weeks, waiting for placement. Over my first 2 years as an attending psychiatrist, I treated only a handful of kids who had to stay on the unit for more than a couple of weeks, waiting a safe discharge plan. Fast forward to last fiscal year, over the span of just 8 weeks, I admitted 4 children under the age of 9 who ended up in overstay status, and that spanned from anywhere from 4 weeks to 4 months. Since July, our children's hospital downtown has cared for at least 20 children who remained in the hospital for more than 24 hours after medical clearance, for a total of 450 overstay days in an inpatient unit or the emergency department. The behavioral health system currently lacks the capacity to meet the state's needs. A common theme between the hospital and residential settings is a never-ending staffing shortage. There isn't enough staff for the number of potential beds, and there's a high turnover rate, often due to burnout. Similar to how kids get stuck in the hospital waiting for residential beds, they can also get stuck in residential treatment, waiting for an appropriate placement in the community. Senate Bill 696 aims to prevent future bed closures in the residential and respite settings. Our social work team works closely with the child's local DSS team to secure appropriate mental health services by the time of discharge. But this bill would streamline this process and help to decrease the length of time these children are stuck in the hospital. For these reasons, I urge a favorable committee report on Senate Bill 696. Thank you.
Last, for this panel, we have Catherine Whitaker, who's testifying virtually in favor. Catherine.
Thank you, and good afternoon, Chair Bidle and Vice Chair Hayes, for the opportunity to address the committee and your timely concern and attention to this issue. My name is Catherine Whitaker. I'm the Director of UPMC Western Maryland Behavioral Health Services, located in the rural region of Cumberland, Maryland. We serve the residents of Allegheny County and the surrounding counties in Maryland and West Virginia. UPMC Western Maryland has always worked to improve the access and coordination of the care for the behavioral health services. We are trying to increase access points for the individuals to receive the right level of higher level of care. And we support the Senate Bill 696 especially with the least restrictive setting language. To that end, we have embedded behavioral health specialists in our primary care offices and enhanced our telehealth capabilities to strengthen our collaboration with our local and regional partners with the intent to meeting patients' needs. Given our rural location, there is often a lack of resources for adolescents, especially for care for adolescents with a severe autism and aggression. The bill's provision for the Maryland Department of Health to conduct a review of the residential treatment centers and respite facility rates is much needed. Over the past 2 years, we've experienced several pediatric overstays in our ED, with our most recent lasting upwards of 7 weeks, with many denials from placements. Although we're fortunate to have a low number of pediatric overstay incidents, each one dramatically impacts the mental health in the youth, and it delays their ability to receive care in the most appropriate care setting. First and foremost, for the safety reasons, one-to-one staffing care is often needed for the youth in the emergency room setting. This poses challenges around the hospital staffing and throughput issues. Secondly, there's limited educational support from the school system and delays in the process. And third, communication among the agencies is often disjointed. We respectfully ask for your favorable support for Senate Bill 696.
Thank you for your testimony. Are there any questions for this panel? Senator Lamb.
Thank you, Vice Chair. Thank you to the panel. Just had a follow-up question, just kind of given the circumstances that have had some concern over the legality and patient mental health impacts of having kids stuck in hospitals rather. But I was looking at the committee testimony. There's some interesting testimony from Venable that raises some notable points. Specifically, they note that in Baltimore City, only 7.5% of pediatric overstays are actually ultimately placed in a residential facility. So it means that the vast majority were in need of some sort of community placement, for example. Would there be openness to an amendment to look at some language related to the need for more community placements, given kind of where a lot of these individuals end up?
Yes, Senator Lamb, I can say absolutely. We would love to see more capacity across the continuum of care. In the data collection that we've done, we have seen the majority of these kids are awaiting residential treatment. So that's, I guess a little out of line with what was in there. But we know that there's need, not just at the residential treatment center, but at everything between that and wraparound services at home, group homes, therapeutic foster cares. We'd love to see more of all of it.
Got it. Okay, thank you. To tag along to that, I guess in reading their letter, this Venable letter also highlights an issue that it seems like under the bill, hospitals will be looking for potential out-of-state placements for kids. Would you also be open to clarifying that the kids are ultimately under the custody of the Maryland Department of Health and Department of Human Services, so that those agencies should ultimately be responsible for placing these kids? Just really kind of the thought that for kids that are in custody of the state should ultimately be responsible for what happens to them.
Yes, that is the intent. We were able to meet with the gentleman from Venable, and that was definitely the intent of that provision within the bill. Was simply right now, hospitals are forced to exhaust to actually get a no response from every in-state facility before anyone will pursue an out-of-state option. And so to simply facilitate more expeditiously finding, a placement for the child, can they be pursued at the same time, but certainly through the appropriate agency.
Okay, and just making sure that agency is still ultimately responsible for these children. But there, I guess, a letter from the Venable letter and also from Disability Rights Maryland, they do highlight a lot of concern regarding RICA, right? And so, not exactly sure where the answer are to those concerns, because it's a really complex, issue and problem. But I was wondering if there's any thought on how we can help ensure the kids that are at RICA are getting the best possible care. Obviously, in part here is to make sure they're fully staffed, or staffed up, rather.
Well, I don't mean to hog the mic from any of the experts on the panel, but so if anybody has any thoughts, please let me know. But yeah, I think absolutely. We did meet with these advocates. I think open to thinking that through, how that can be done. And if RICA isn't the most appropriate place, is there a way to direct funding to a more appropriate, setting?
I think, Senator, to your point about increasing funding towards other placements. I think a lot of kids get stuck at RICA and other in-state residential treatment centers waiting for those community placements. And so those children, while having receive the maximum benefit of the residential program for that time-limited setting, then they stay there for years and are likely to decompensate because they're never able to progress to that next level of care. So I think that speaks to the point of trying to increase community placements as well.
Okay, that's helpful perspective. Last question, I think this question is for Ms. Manna. Can you speak to the process difference between those who are under state custody, children who are under state custody, and those who are dropped off by a parent and who are not allowed for the child to come home?
Sure. So if a patient is in the custody of the state, we are simply then contacting the worker, we're contacting 211, we're convening meetings with various agency representatives of the child who the state has custody of. Routinely, it's done on a weekly basis, and those various agency representatives are reporting back in that meeting about their ability to make referrals for placements in the community and what those responses are. That is a little bit more straightforward than the situation where you have a parent that, out of desperation sometimes, is refusing to take that patient home. So at some point, the hospitals were able to contact Child Protective Services. Child Protective Services would become involved. That is not the case at this point in time. The hospitals are forced to request a local care team meeting. Those local care team coordinators involve the parent, who has already said, by the way, I'm not taking this child home, to activate community resources to ideally then support the patient and the family back in the home situation. That process, there is no sense of urgency around that whole process. The two of my adolescent females right now are going through that process. As I said, one has been there 36 days, the other 21 days. We've had one meeting for each of them. Once you get to that process, you have to exhaust all of the outpatient care coordination resources that would support that patient and family before you can take it to the next level, which potentially could be a voluntary placement agreement. And I can tell you that that application and that process is 13 pages long. And once you get past the voluntary placement application and you've exhausted potentially group home resources, if they even exist and are available for this patient, then you might go down the path of proceeding towards an RTC placement. But in that instance, you have to have a psychiatrist that recommends it, you have to have a completed certificate of need that gets approved, and then you have to make referrals to in-state facilities, which has already been pointed out, you cannot make those referrals simultaneously to inpatient and out-of-state facilities. Once you do exhaust your in-state, to go out of state, if you find a bed, then there has to be funding approval on top of that. We've had patients in our ER waiting for residential placement. We've worked with BHA, DDA, DSS in those cases. That patient was in my emergency room for 4 months, not getting the care that they needed. So it's a very convoluted process with many players involved. Having one person on point to coordinate that and actually have some authority to move things along with the same sense of urgencies that hospital emergencies rooms have to deal with things would be helpful.
Thank you.
You're welcome.
That is a very convoluted process that you just went through in like 2 minutes. Thank you.
Yeah, thank you, Senator Lamb. I have a quick question. Ms. Manna,
Yeah.
what is preventing the hospitals from calling CPS?
Well, we call CPS.
No, what you were saying, it used to be you'd be able to call CPS.
Well, we would call.
I'm sorry.
Yes.
You used to be able to call CPS, they would respond, but now you have to go through a separate process where there's a local management team. What's preventing that call from CPS?
So we call CPS.
Mm-hmm.
Their response to us in this last instance was, you need to call the local care team for a meeting, because CPS does not
What do you mean in this last instance? Is there a law? Is there a policy? What's preventing you from calling?
There has been a practice in the hospital emergency rooms that when we have a child who's abandoned by a parent, to contact CPS, because we have no authority over decisions for that child or placement of that child. CPS in the past has been more willing to become involved. Of late, we have not seen that in the last 2 instances
But
of
there's
adolescents.
nothing in the law that's preventing you from calling CPS.
No, no.
You're experiencing an incident
Yes.
where that is taking place.
Yes.
Got you. Okay.
And if I could just add, what we're being told is that the abandonment of that child in our emergency room, even though it might be made out of fear of safety for the parent, other children in the home, or the child or adolescent, does not necessarily constitute neglect. And I was provided federal regulation stating that.
Got you. Okay. Senator Reedy.
Thank you. Thank you, Mr. Vice Chair. And I'm real supportive of us wanting to address this issue, and I know it'll help on a number of levels. I guess I'm curious, and I don't know who to address this question to necessarily. So we have some of these children who are essentially the state's responsibility. They don't have a parent or guardian in the picture, or for whatever reason. But some of these children do have parents or guardians in the picture who have brought them to a hospital because of behavioral and mental health challenges. That's fair to say, right? And they're still in the hospital because the parents really felt they could not control them, could not figure out how to meet the needs that they had. And we can't release them back to the parents, as I understand it, because, can somebody tell me that again, why we can't release them back to the parents?
They simply refuse to pick them up.
I'll add to that, though. Also, I think it's a little more complicated than those two ends. There's a middle where the parents want them home after they get eventual treatment, but the next recommended level of treatment is residential.
And we can't get them into residential.
Right.
And so they're
Or a
still
day program, which is right under that, where they go for the day but live at home, and we may not be able to get them into that.
for weeks and weeks or months.
Months,
sometimes.
right, yes.
Okay, right. That's right. So that's part of what the bill I know is trying to address.
Yeah.
When that happens, what happens now on the parents' end from the perspective of the providers or the health department or whoever is the interfacing agency? We're talking about wraparound services, but what can be done to give them the tools? Because I feel like, and I understand these are real severe cases, but it's starting to become more common. And I suspect that in some cases, it's a challenge of a parent overwhelmed, not understanding their role as a parent. And sometimes a child that there's things they need to do for the child or with the child, and not able to do it. But it's not because they're not able, it's because they don't know. So what is part of what we do already, give them some training, some help, some mentoring, or kind of what are we doing on that score?
I think that was the intent of the LCT meeting that she's speaking of, that was the intervention applied. And I think what we've seen, at least at Shepherd, and I don't know if you have too, but at LifeBridge, is that those meetings start, the parents ask for help, and there's just this months-long in-between of back and forth communication between DSS, between the parent, and there's no sort of end game in sight, like make a decision by this date if you want to move forward with asking for RTC services. And so it just sort of gets lost in the ether.
So does this bill help address that issue?
It does, because I
timeline
think this ombudsman kind of idea is what's helpful for us, because we have smaller meetings with local state folks every week, and they're doing their best, to be honest with you, to help us problem solve, but their hands are tied as well. And so having that centralized person to be able to speak about multiple agency issues across multiple counties, we're all taking patients from every county in the state of Maryland. So you're dealing with DSS in one county, DSS in another county. This will really help centralize and have an end game for all of us to communicate.
That's good, because in tandem to that, or as part of that, I really want a parent to be challenged that we understand you're overwhelmed and we want to help, but we also want to get you to a place, except in really extreme circumstances, where we don't want the state shouldering this for any longer than we have to, in the sense that we want to get it made right and restorative, So I I think that's important, but I appreciate your answers. Thank you.
Can I add to that quickly? So also the standard of care for inpatient psychiatric units is a weekly family therapy session. So that continues. Even it's kind of like a medical patient still being on the pediatric intensive care unit, receiving all of those resources when they don't need that. The patient's still getting the care of the intensive inpatient psychiatric unit. So I think that is aiming to help that as well. So that care still continues. Mm-hmm.
Thank you. Senator Ellis?
Yeah, thank you, Ms. Vice Chair, and thank you, Senator Vital, for this bill. It seemed like a very big problem. It seemed like I kind of, listening to the panel, understand what the problem is, but I'm trying to get to the solution in my brain, and it's not as clear, so forgive me. I might be having a slow day. So I'm looking at the fiscal note. It talks about $4.6 million funding beginning in 2027, provide funding to fill all authorized RECA positions. So I'm just trying to listen and follow, and I can't do a search. What's a RECA positions, RACA? Who knows that answer?
RICA is one of our residential treatment centers.
I'm sorry, I can't hear.
RICA, it's the residential treatment center.
Those are the ones that are operated by the state of Maryland.
And that's the name of a place?
There's 2 locations in Maryland, one in Baltimore City and one in Montgomery County.
The Regional Institute for Children and Adolescents.
Regional Institute for Children and Adolescents.
Mhm.
And those are
RICA.
2 facilities?
Baltimore and Rockville.
Baltimore and Rockville. Okay. So what are those names of those facilities, those 2 facilities?
They're both called RICA.
RICA Baltimore, RICA.
RICA.
Okay.
And then there are a handful of other across the state.
And those are residential facilities?
Yes.
So what you're saying is they would leave the ER, emergency hospital setting, whatever, and go to these facilities? Right. So the problem is that you have a shortage of people working at these 2 facilities that can't take them in?
Right, there's approximately, the MHCC did a study on.
I'm sorry, MHCC, what's that?
I'm sorry, the Maryland Healthcare Commission. We have a lot of acronyms in healthcare.
Yeah, I mean, you try to follow in, people listening at home, people tell me all the time, we just can't understand,
No, please.
you know, so.
So the Maryland Healthcare Commission did a study over the summer around the capacity, residential treatment center capacity in the state. And in that study, they identified that within the state-operated residential treatment centers, which are the RICAs, there were 17 beds that were not staffed. And so those were the beds that, under the bill, were trying to be brought back online.
Okay, so you can't put people in the facility even though there's an empty bed if you don't have the staffing. And so this funding will provide the staffing to be able to have those beds available. Is that
That's the
correct?
goal.
That's the goal. And so the out-of-state placement issue, what's that as far as?
So we simply, unfortunately, right now in the state, we do not have enough capacity, either at residential treatment center or even sometimes lower levels of care. And so right now, in order to pursue an out-of-state placement, it's a rather cumbersome process where you have to go to every single in-state provider first and not just contact them, but contact them and then receive a no, which can sometimes take weeks just to get that. And so the bill proposes to allow those to be pursued simultaneously, in-state and out.
So out-of-state placement is happening now because of the shortage of these available beds. I mean, they're not being staffed.
Right.
So if this fund is available, we will have less placement out of state.
Yes, sir. Well, we hope so, yes, sir.
And that's the goal.
Yes, sir.
Okay.
Just to clarify, sometimes out-of-state placements also occur because every in-state RTC is denied the patient due to the level of
RTC?
aggression.
RTC?
Residential treatment centers.
Residential treatment center,
okay,
sorry.
yeah. How many of those we have in state?
Right now, 3?
Four for adolescents and 1 for children, 5
So
to
there are
12.
residential treatment centers, and there's 2 other hospitals. So,
Right.
2 other homes, sorry.
The 2 RICA
Right.
facilities are also residential treatment centers.
So it's a total of 4.
4 for adolescents and 1 for children.
4 for, okay. All right. And so this bill will make more out-of-state, or cut down out-of-state placements.
We hope
As
so,
currently.
yes.
That's the hope.
That's the goal.
Okay, all right, great. Thank you. Appreciate that.
Got you. Thank you, Senator. Thank you, Senator Ellis. Is there anyone on the panel that know of a situation whereas there was an organized effort to try, because I agree, I think the problem is great, right? I'm not sure quite what the solution is. This solution seems a little bit more balanced towards shifting it away from hospital resources. But has there been an organized effort so far to pull all of the parties together to try to find solutions to address this problem to date? Anyone familiar with that?
So this has been, yes, but I think it could be stronger. I'll say that. I know that hospitals have been talking about this for some time, and we have had various meetings that look, I think, like what you're thinking of, but they have not gotten the traction, I think, that we would like to see, because if I know where you're going.
Right, so more specifically, like, has there been a meeting of like the hospital administration, the Department of Human Services, the Department of Health with, at a like secretary level that could sort through all of the different nuances here to try to establish some type of solution?
There have been a few of those. And then there's actually ongoing meetings right now between, of that nature, actually, organized over on the House side. More centered at this point in time in session around this bill and what's going on here, but those meetings have taken place in the past.
Right, and so the bill before us, though, isn't like a product of any of that work. That work is happening as a result of this being presented to the legislature.
The current work, yeah.
Got you. No, that makes a lot of sense. And what are the options? Like, say to Senator Ellis's, suggestion that we don't have enough beds or whatever, and what happens to a young person? Because obviously these young persons, especially the ones that are in care of the state, are there for a reason. There's a responsible adult who's neglected to care for them and had led them to this situation, right? I think, transferring people out of the state may cause some of the same traumas that you guys have already shared with us today. But what is the consequences if, say, there's a referral and there is no placement, right? I think the problem that you're trying to get at is, that the hospital is not the appropriate setting for someone that has dealt with that type of trauma. And if there is no other alternative, like, what do we do at that point? Has there been any consideration, any thought around, like, what happens in that case?
Honestly, the consequence is that the child remains in the hospital indefinitely.
Yeah.
And the children that need medical care, surgical care, additional psychiatric care, they don't get it in the state of Maryland. They get sent out.
They don't get that in a hospital?
No, I'm saying when our beds are filled, we have certain medical beds that are filled with these kids we're talking about now. We are not able to accept a
Got you.
new
Clear about that. I'm worried about the kid that's been traumatized, neglected, put in a placement. The social worker won't pick them up. A parent won't pick them up. What happens to that kid? I get your resource problem. You guys have made that really clear. I'm trying to find out what is the consequence with that child.
I'm sure it's fair to say that every member of this panel does absolute best for the children that are under their care. I think the thing that makes it increasingly difficult is that these children need so much more, and we are also denying care to children in Maryland and sending them out of the state to other facilities and paying for that on top of it as well. So there's two big problems that we all need help with here.
Right. So bottom line is they wind up staying in a hospital, which causes an undue burden.
They just stay and get further traumatized, to be honest with you.
Yes. And it is not an ideal setting. We do care for them. We don't neglect them. We give them what they need. But what they really need is to experience life, experience childhood, experience adolescence, so that they can help and grow and mature in a way that'll make them more productive members of society.
Yeah, no, I think I agree with you. There's a problem, right? There's a systematic problem that needs to be addressed. I'm not sure if we've identified the solution to meet the problem yet, but there's definitely a problem that needs to be addressed. I'm glad to hear that this has been, because the chair and the folks in the House have brought it to everyone's attention in the form of legislation, folks are willing to come to the table. But, we are talking about vulnerable young people. And to your point, finding a solution that is appropriate to their healing process as opposed to further exposing them to the traumas that society present to them. And so I think that's the ideal kind of result that we would like to get from this situation, where young people in the state of Maryland are cared for in a way that's respectful of where they are and their vulnerabilities here in our state. So thank you so much. Are there any additional questions from this panel? Thank you for your testimony. We do have some additional testimony in favorable of this bill. Next, we have Dana Kaufman, Ann Geddes. I hope I pronounced that right, Ann. I apologize if I didn't. And Tanya Swartz.
Good afternoon, Mr. Vice Chair, members of the committee. For the record, Dana Kaufman on behalf of MedChi and the Maryland chapter of the American College of Emergency Physicians. We are also in support of this bill. Boarding in the ER for these pediatric patients is a significant problem, as you've heard. The ER setting is the least therapeutic for these patients, and that is why we definitely do support this bill. I don't want to repeat the previous testimony, so I will just say me too, and we're very willing to come to the table and work on a solution. Thank you.
Thank you, Mr. Vice Chair and committee members. My name is Ann Geddes. I'm with the Mental Health Association of Maryland here in support of Senate Bill 696. This committee's been hearing about the hospital overstay problem for years now. MDH and DHS have taken some measures to try to address the problem, but it is not enough. It remains. That's why we need this bill. Maryland's most vulnerable youth, those kids who are in foster care, youth who have co-occurring mental health and developmental disabilities, and kids with the most serious and complex behavioral health needs are the ones who continue to be stuck in emergency departments. And everybody said it does a ton of harm to them. So further steps need to be taken to address the problem, and we welcome all the measures proposed in Senate Bill 696. These measures come at some cost. The bill does have a fiscal note, but our most vulnerable children need it now. We strongly concur with the bill's requirement that MDH undertake a rate study to right-size RTC reimbursement rates, as well as study a prospective payment model for RTCs, because a big part of this problem is that Maryland RTCs are not paid enough to fully staff their programs or appropriately treat high acuity children. In November 2024, this was just 4 months ago, the 5 RTCs reported, and they do this every month, report on their licensed capacity and their operational beds. In November 2024, they had 317 licensed beds, but only 207 operational beds. This is largely due to staffing issues. And as was said, I will just add quickly that residential treatment beds are only a part of the answer to this problem. Maryland needs a broader array of quality, intensive, community-based services, such as high-fidelity wraparound, and we need crisis services for kids. Keep these kids out of the hospital in the first place. Robust crisis services designed specifically for kids and families. So I ask for your favorable report. Happy to answer any questions.
Absolutely. Thank you all so much for your testimony. Are there any questions for this panel? Senator Mouse.
Thank you, Mr. Chair. And my question will be very quick. And the last panel was very informative. I understand the concept. However, I'll ask Dana specifically. Perhaps, I don't know, I'll only ask one witness question, but, there's 2 facilities where these children can go. As you couldn't be as far from the Eastern Shore as you can imagine. So I guess as this bill is being put forward, how would you address that for my constituents and up and down the shore, north, and further east, and even south?
As far as
what does it do for them? How will it help them?
Well, I mean, I think the biggest issue, again, is what I had said before. So many of these children or pediatric patients are boarding in emergency departments, and they're not getting any service. So I understand your concern as far as the distance. I think that is something we're going to have to continue to look at. And maybe that is also where we start looking at some of the community options as well.
And I'm not suggesting that that would undermine what the intent of what this bill is, but, when you talk about, Easton Hospital last September, the average wait time was 24 hours. I mentioned at a hearing earlier, that's 24 hours in the ER. You can go to that ER and there's children in there almost guaranteed. And so I just wanted to make sure that that was considered. I know the discussion is about the bill. This is one step removed. However, there is another half of the state that is also dealing with this, and this is a significant issue. So thank you for considering my question.
I was just going to say, there are 5 RTCs in Maryland. They're all in central Maryland. There used to be one on the Eastern Shore, which shut down with a lot of others. Again, issue of rates, adequate reimbursement, and being able to fully staff these facilities.
Yeah, it's not a criticism. I'm a senator, so it's my responsibility to fill that, right? No magic wand here, but I think it's important. The first thing is to talk about it and make sure that people are aware of it. So thank you.
Thank you, Senator Miles. Tanya, did you want to provide your testimony?
Sure, thank you. Good afternoon, Vice Chair Hayes and committee members. My name is Tanya Schwartz.
Pull it closer to you.
Oh, sorry.
The mic moves.
It'll come
to you. Yep.
There we go. How's that?
Fantastic.
Great, thank you. Good afternoon. My name is Tanya Schwartz. I serve as the Director of Urgent and Acute Care at the Maryland Department of Health Behavioral Health Administration. The Maryland Department of Health thanks the committee for the opportunity to provide support with amendments for Senate Bill 696. The department fully supports the intent of this bill to ensure that youth with complex behavioral health needs receive clinically appropriate care to support their health and well-being. There is a collective understanding, as you've heard today, that this is a critical issue that really needs to be addressed across the state. Over the last 2 years, we have been working closely with key partners to identify solutions and have leveraged additional assets to support this endeavor. Today, we would like to recommend amendments to SB 696 in 5 areas that we believe will enhance the legislation and the state's ability to address hospital overstays. First, based on 1121 of 2020, the department is procuring a software vendor to establish a bed registry and referral system. The department proposes an amendment to require hospitals and all inpatient, outpatient, and crisis behavioral health providers to provide information and update service availability in real time. Second, the department seeks to clarify the scope of children experiencing a hospital overstay who are included under these bill terms. So we recommend defining a hospital stay as a stay that exceeds 48 hours in the emergency department, which aligns with the time frame in COMAR 2131. The department proposes an amendment that if a patient exceeds 48 hours in the emergency department and the hospital or bed registry shows availability for an inpatient bed, that the hospital will seek appropriate transfer to maintain the clinical stability of the youth. Third, the department proposes an amendment to ensure that youth are stabilized under the Emergency Medical Treatment and Labor Act, referred to as EMTALA. In our written testimony, we've provided a number of recommendations. Again, we fully support this bill with these amendments, and we look forward to working with hospitals and other stakeholders to really build the full continuum of behavioral health care for our youth across the state.
Tanya, thank you for your testimony. When you talked about the 48 hours, you're talking about 48 hours after they've been medically cleared to no longer be appropriately served in the hospital. What is the 48 hours?
Yeah, so the 48 hours aligns with the bed registry and referral bill, which is at COMAR 102131. Of course, I didn't print that one, printed the other ones. That just defines what it means to be in an emergency, to be in a pediatric hospital overstay. So it's 48 hours, and as you've heard today, right, we all care about making sure that our youth are in the most appropriate clinical setting for their needs and that they're getting the care that they need.
But I guess, you're not talking about 48 hours stay and the like anything over 48 hours would be considered an overstay?
An overstay.
Got you. Okay. All right, interesting. Are there any additional questions from this panel? From Tanya? Thank you so very much. Let's go to our virtual testimony from Mr. Mitchell Mervis.
Thank you, Vice Chair Hayes. My name is Mitchell Mervis. I'm an attorney at Venable LLP in Baltimore. For the last 37 years, I have been counsel for the class of Baltimore City foster children in the federal case of LJ versus Lopez, used to be LJ versus Masinga. Also, I am co-counsel with Disability Rights Maryland in the other federal class action case, TG versus Department of Human Services, involving hospital overstays for the rest of the state. So I represent all of the foster children. To put it simply, we have been dealing with this issue for the last 6 years, trying to get the Department of Human Services and the Department of Health to solve the problem to no avail. We have resorted to litigation because, quite frankly, nothing else has worked. I support this bill. However, I think amendments are necessary. Hospital overstays are a tragedy and a travesty. They are horrible for children. It is impossible to overstate just how bad they are. But some things to know. Number one, RTCs, more RTC beds, particularly at RICAs, are not the solution. Only 7.5% of the Baltimore City foster children went to RTCs during fiscal 2023. In fiscal 2024, 88% of the Baltimore City children in hospital overstays went to community placements. A majority went to foster parents, parents, and relatives, a majority. So highly intensive treatment programs are not what we need. Children loathe RICAs. And I tried to submit an article from Silver Chips, the Montgomery Blair High School student newspaper, that did a fantastic article about RICAs. Children think they are prisons. So I urge you to strike that provision. I have a number of amendments that I have proposed that I think would help make this a much better bill, but I think we need a lot of focus and a lot of work on this problem because, quite frankly, it's been 6 years and the state has failed to take the steps necessary to even begin to address the problem.
Thank you, Mr. Mervis. Much of your testimony was Baltimore City focused. Do you have any knowledge of what is existing in other parts of the state, or is it just specific to Baltimore City, or is Baltimore City a representation of probably the system across the state? Vice Chair Hayes, in fact, the problem is worse outside of Baltimore City. The federal case has brought more services into the city, quite frankly. So, for instance, we've been told approximately 140 children outside of Baltimore City have been in hospital overstays in just the past 2 years. Those are foster children. The number of children who are not yet in foster care but have been abandoned by their parents and are waiting for foster care placements is unknown, but clearly in the scores, probably the hundreds. And what happens is the hospitals try to get DSS to take the children, but DSS simply will not take the children until it has a foster care bed available for them. So there is a huge backup. Adding a few RICA beds is not going to solve the problem. We need in-home services wraparound that can let these children go to the community where they end up anyway eventually. Thank you for your testimony. If you hold on just a second, we have some additional questions from Senator Ellis.
Yeah, thank you, Mr. Vice Chair. And so when I thought I have the answer, you came along and told me that what I thought is not really answer, is it Mervis?
Mervis.
Mr. Mervis, yeah. So you don't like those residential facilities, not residential, those two hospitals, right? Is that what you're saying? You don't like them because you think they're prisons? Is that what you
Kids think they're prisons. And as I said, the Blair High School newspaper.
Is there a survey you have to let us know that? How, I mean, you just said the kids, and how do you come up with that particular phrase? Because that's a strong phrase you use.
That
They
is
think
the
they're prisoners.
title of the article in the Montgomery Blair High School student newspaper where they interviewed students who had been in Rikers who were attending the school. So that's not my term, but I've represented Senate foster children at Legal Aid for 5 years, and I regularly consult with Senate attorneys who represent the children in juvenile court, and that is a universal feeling that the Rikers really are the worst placements in this state.
I understand you're quoting a student newspaper, but I mean, our students are great, they're smart, but any data surveys to say, to give quantitative backing to what you just said?
No, sir.
I'm sorry?
No, sir. No.
Okay. So as an adult, you're quoting kids to say how bad something is? I mean...
Sir, as I said, I've practiced in the area for decades. I've had many Senate clients myself. I work with Disability Rights Maryland very closely. I speak to Senate attorneys who represent the kids all the time. I feel very strongly that Rikers are the least the placements that foster children dislike the most.
Okay, I understand what you're saying, and you keep saying the same thing over again, but all you can do is say some student newspaper said this, and this is proof. When you're a grown man working in the field, you should come to us with more quantitative, maybe peer research data. I mean, this is important decisions, and you just can't just blow our minds like this, saying that some kids at some high school wrote an article saying this is the worst thing, they're like prisons, and just blow up the hearing like that. I mean, it doesn't. I thought you had really good data, being a law firm, experienced man with law cases, all that stuff. Could you go and get that data for us and come back and give me maybe save your reputation? Because that's unacceptable, really, coming here saying a kid newspaper said X, Y, Z, and these people who came testified before with solutions, with facilities and how to help the facilities, you say, oh, they're prisons. I mean, that's not fair to the system, I really believe. So thank you, Mr. Chair. I appreciate that.
Thank you, Senator Ellis, for your questions. Mr. Mervis, one more question. I know that you, to the Senator's point, in your classification of RTCs, you made a recommendation that there's a more preferable placement. And could you talk a little, explain that part a little more?
There are private sector RTCs that, like St. Vincent's Villa, that do a very good job for children. I am a fan of that program. There is Woodburn. I mean, there are other residential treatment centers in Maryland that do a better job, in my opinion. There are also intensive group home placements. We had, I know of one child at Northwest Hospital who just spent nearly 80 days in the emergency room. A very sad case, nearly killed by his father, traumatic brain injury. He spent a month, I believe, at Hopkins before he came into care. Went to a group home that didn't work, and then went to Northwest Hospital ED, didn't get education, didn't get therapy. We only found out about it because he was hit and assaulted by another ED patient, and that was noted by the department. We alerted to us. I wrote to the secretary, and the secretary found a group home placement for him where he's doing well. The Board of Child Care, which has a high-intensity new group home program. There are a lot of different models of placements that are available for these children that should be expanded, and one of the amendments that I've proposed is to have the Department of Human Services and the Department of Health actually work together with these placement providers, with Disability Rights Maryland, the Office of the Public Defender, which also represents these children, to come up with an actual working plan and an assessment of what we need. So we actually can say we need these kinds of beds in this amount so that we can properly plan for the children.
Right. Was it also your testimony that the majority of young people are not being placed in more restrictive RTCs, but being placed in community based placements, is that when you describe the 88% of them, it was not that they're going to the restrictive placements, but the less restrictive community-based placement?
That's correct. 88% of the children in Baltimore City from June 8th of 2023 to May 31st of June of 2024 went to parents, relatives, foster homes, or group homes. More than half of them went to parents, relatives, and foster homes.
Gotcha. Are there any additional questions for Mr. Mervis? Thank you so very much. There are no more questions and no one to testify on behalf of this bill. This ends the bill hearing on Senate Bill 696. Way back up, I think we had Senator Rosenpap. Oh, there he is. You want to come up, Senator Rosenpap? Yes, Claudia Baylog, Carolyn Taylor Chester, Rhonda White, Tammy, and Megan Peters.
Thank you, Madam Chair and members of the committee. This is an issue that you've dealt with before, and even similar bill you've dealt with before. It basically deals with the pay for folks who work in these facilities. And we've had bills over the years to require that a certain percentage of what Medicaid pays go towards employee compensation, and it varies across providers. This bill essentially would do the same thing as submitted. We've submitted amendments that are more along the lines of a study. With that, I'd like to turn it over to the panel because they've been working very hard on this and working with the health department on the details.
Good afternoon, Madam Chair, Mr. Vice Chair, members of the committee. For the record, my name is Claudia Balog. I'm the Assistant Director of Research with 1199 SEIU, and I'm here to testify in support of SB 679 with the sponsors' amendments. I think it's helpful to understand how we got here and why the state needs to analyze how nursing home revenues are being allocated within our facilities. So as Senator Rosenpap said, we've supported legislation for a number of years that would raise Medicaid reimbursement rates for providers while mandating that a portion of those rate increases are passed through to workers. Even without the budget crisis, though, that we face right now, 1199 takes the view that a good approach to this workforce shortage problem is to mandate that a percentage of a nursing home's revenues are directed to wages. Now, I've reviewed cost reports from many facilities and chains. There are facilities, nursing homes in the state dedicated to providing quality care and addressing short staffing. But then there are others. Some are acquired by private equity or similarly structured ownership entities, and those numbers tell a different story. I've seen cost reports where operators pay increasing amounts of money toward rent expenses each year to building owners who also have an ownership stake in the nursing home. These complicated business structures make it easier for individuals to profit off of a nursing home and allow institutional owners to make decisions that don't put quality at the top of the priority list. Finally, I want to note that in Massachusetts, where by regulation, 75% of a skilled nursing facility's revenue has to be allocated to direct care and wages, nearly 80% of that state's nursing homes meet or exceed that threshold. So the kind of analysis that's being called for in this bill to see how dollars are being allocated would allow Maryland to set our own direct care spending floor. Thanks.
Who would like to be next? Go ahead. Go.
Good afternoon. My name is Rhonda White. I am a certified medicine aide at a long-term care facility and a union delegate for 1199. I support SB 679, the Nursing Home Care Crisis Transparency Act. This bill would help fix the staffing crisis because knowing how nursing homes spend their money will improve working conditions and quality of care for our residents. Healthcare workers made sacrifices on the front lines of COVID-19. Some of us survived, others lost their lives or left healthcare. Those of us still working are dealing with a short staffing crisis. This problem before the pandemic, but it's even worse now. In my facility, we have 1 GNA to 20 patients. We provide high-quality health care, but can't be everywhere at once. This is bad for residents and for workers, too. When we don't have enough workers, our mental and physical health suffers. We are stuck in a cycle of not having enough workers. So many workers burn out and quit. Then the short staffing cycle continues. The root cause of the short staffing crisis is low wages. Recently, I was conducting a new hire orientation. When I told the new GNA what her wage would be, she told me she would be right back. Then I looked out the window and saw her driving away and never heard from her again. This is just one of many examples. Senators, you have the power to break this cycle. Vote yes on SB 679. Healthcare workers care for you. Please care for us. Thank you.
Good afternoon. My name is Carolyn Taylor Chester. I have been working as a GNA in long-term care facility for over 30 years. I love connecting with the residents, and I go above and beyond what I am paid to make sure that they are safe and cared for. I support SB 679 because workers and residents in nursing homes deserve better. Recently, I was the only GNA shift working with 41 residents. There should be 3 GNAs on the floor, and many are being missed. When we're short, residents are left waiting for care, the care that they need. They get frustrated and overwhelmed, and understandably so. It's not fair that they should have to wait for care. We also don't have enough supplies. Workers sacrifice our own health when our facilities are short. This month I took time off because I had a medical procedure. While I was still recovering, I got a call from the manager asking me to come to work. And even though I was not able to, she just kept talking to me and trying to debate me into coming, and I'm sitting up there saying, I'm not able to come to work. They really don't care for the residents and staff like they're supposed to, but I also need to care for myself. Instead of being able to focus on my healing, I was worried about my residents. That's not right. Maryland needs to do a study on our long-term care system to improve it. Vote yes on the Nursing Home Care Crisis Transparency Act. Thank you very much.
Good afternoon, Chair, Vice Chair, members of the committee. For the record, my name is Megan Peters, and I am the Director of Government Affairs for the Alzheimer's Association in Maryland. And I'm here in support of Senate Bill 679 with sponsor amendments. The largest segment of workforce that supports people living with dementia is our direct care workforce. As of 2024, an estimated 46% of nursing home residents nationally have Alzheimer's disease or another dementia, and many of our direct care workers interact with these residents daily. We know that more direct care workers will be needed in the years ahead as our population ages and the prevalence of dementia increases. Currently, there is a staffing shortage and staffing challenges, which are driven in part by low wages. This can impact the quality of care, which is especially concerning given how acuity levels are increasing in nursing homes. For example, many people living with dementia also are facing other co-occurring chronic diseases. This bill takes a step to address these concerns. Currently, there is limited fiscal transparency on how Maryland's nursing homes spend their revenue. With these sponsor amendments, the bill will provide insight on how much revenue is being spent, and we can use this to later establish a strategy that guarantees an investment into direct care and those staff that provide the care. This bill will move us in the right direction to improving the safety and well-being of our nursing home residents, and we urge a favorable report with the sponsor amendments. Thank you.
Thank you, Megan. Dr. Moran, you're favorable with amendment.
That's right.
Okay. Let's see if we have any questions for this panel first. Senator Jackson?
Thank you, Madam Chair. This question is for Ms. Barlog. What do nursing home cost reports in Maryland currently collect, and are we getting the full picture?
Okay. So I like to say that our nursing home cost reports in Maryland ask all of the right questions. They actually are quite detailed. They give us the utilization rates in nursing homes. They tell us how much revenue comes from each payer source, like Medicaid or Medicare or private pay. They give a lot of line item details on expenses, on salaries in the nursing department, ancillary costs, administrative expenses. They give us the value of assets. If the nursing home owns the building, we see the value of the building. As I noted before, if the operator is paying rent, we see how much rent they're paying. And they're supposed to get really good information on ownership. Who owns the nursing home? What are their salaries that they're taking home? And what related party businesses those owners are invested in. What's missing? Well, first I'll say that the cost reports aren't audited, and the details about ownership and those related party transactions are only as useful as the extent to which a nursing home accurately reports the information. So I've seen cost reports with inaccuracies or incomplete data on ownership and related parties. And that's important because that's often how profits are hidden. Profits can get siphoned off as expenses to a related party business. But I would say for the purposes of this analysis, to understand how much revenues are being used to support wages, we can get decent data from our existing cost reports on exactly how nursing homes are allocating those dollars.
Senator Ellis?
Thank you, Madam Chair. So thank you, Senator Roosevelt, for this bill. Senator Jackson asked a question, because you said in, I think it's one state, 80% of costs go to direct care. Which state was that?
I believe the 80% is New York.
Okay, yeah, that's what you said in your testimony. Right?
My testimony referenced Massachusetts.
Okay, yeah, exactly.
And Massachusetts, 75%.
75%. You think New York is 80%. Mm-hmm. So, I mean, Senator Jackson asked my question, and I didn't hear the answer. Mm-hmm. What percentage in Maryland? Can you guess? You don't know?
We don't know.
It's a mystery. You can't figure it out.
You can figure it out. It's just, it's a complicated analysis. You would have to look at, you would look at 225 roughly cost reports.
Have you looked at any of those?
I've looked at some of them.
Give us a number.
I think it ranges. I think there are skilled nursing facilities that are paying 75, 80% of their revenues, allocating it towards direct care. Mm-hmm. And I think that there are some facilities where it may be as low as 40%.
Okay, so I got it. Okay, but it's too much thinking to come up with a number for everybody.
It's really important, I think, for the state to start digging into the cost reports and getting that number.
Yeah, so this bill, Senator Roosevelt, is it like a work group or a study? Or? As amended. As amended, okay.
Would one of the witnesses like to address it with the amendments?
Okay, well, I guess you'll be recognized later, but yeah. So it's amended to make it a work group.
It's amended so that the state first does exactly what you asked. What are nursing homes currently doing across the state? And then they can use that data to set that spending.
Okay, can I interrupt you, Senator? We're going to hear about the amendment. Okay. This group is supposed to be favorable.
Yeah.
Then we have favorable with amendment. Okay. So if we can wait, we'll get to the amendment. Okay. Thank you.
Thank you.
Questions, Senator Lamb?
Thank you, Madam Chair. A question for Ms. Balog from SEIU. Can you tell us what do nursing home cost reports in Maryland, and is that giving us a full picture of what's taking place?
Can you tell me what, I'm sorry, could you repeat the question?
What do nursing home cost reports in Maryland currently collect? And are they giving us like a full picture of what's actually taking place?
So, Senator Lamb, I think they're collecting a considerable amount of data. So every expense that they're like a balance sheet, and they are expense statements. And so every expense of the nursing home, there is a line item for. So you can see what are nursing homes paying for the salaries of its nursing staff. You also see where they use, how much they're spending on staffing agencies for each of their cost centers. You can see what they're spending on supplies and housekeeping and dietary needs. And as I noted before, you're getting this good picture of where money is being directed, where I think nationally, and certainly under the Biden administration, there was this real conversation happening about ownership transparency, because it can get very murky, because the business structures of nursing homes are complicated by design. And I think in Maryland's cost report actually has incredible sections that would give you details. You know, if facilities filled out the forms completely, you could see every owner, you could see whether they are invested in a related party business. Like, is there someone with an ownership interest in the facility who also runs a staffing agency, or do they have a medical supply company? You would be able to see that. The issue is that a lot of times those line items are left blank in the current reports.
Oh, they're left blank. Okay. All right, thank you.
Senator, I think we're talking about ones owned by private equity firms, which we've done some legislation on. Thank you, Claudia. Any other questions for this panel? Thank you all. Dr. Moran, you stay, please. And Christina Moore is also here favorable with the amendment.
Great. Thank you, Chair Beidel and Vice Chair Hayes and members of the committee. The department is here in support with amendments for Senate Bill 679. And as you've heard, this legislation as drafted would require a threshold of 75% of Medicaid payments to be made to direct care workers starting at a specific time period. You've heard a lot about what our cost reports collect and what they don't collect. And the amendment that we are proposing would be to acknowledge and also to appreciate the bill's intention to address some of the issues around nursing home staffing and wages. And the amendment would actually propose that we would adjust our cost report collections in terms of what the department collects to get at more granular level data and information so that we could achieve to a data-driven approach for the future. The first step in the process we feel strongly about is to get to your question, Senator Ellis, which is really understanding what the universe is in terms of the percentage of Medicaid payments going to direct care workers, and some of the amendments that we have offered up will allow us to do that. Specifically speaking, related to the time period associated with that, the department will work to revise our cost reporting templates for calendar year 26. So for calendar year 26, we'll be asking nursing homes to collect that information that will inform policy decisions potentially in the future as we look at rate setting, direct care workers, et cetera, in 2027 and beyond. I will also say that we're also in support of the amendment that would require a report of that particular data from the department on an annual basis that would show you what the percentages of Medicaid payments are to direct care workers in terms of our cost reports that we are revising to collect in this regard. So with that, we recommend favorable with amendments. I'm happy to answer any questions you may have.
Dr. Moran, I have two questions. Where are the amendments?
Yes.
Who has them?
So I believe our sponsors have them.
Okay.
You don't already have them, we'll ensure that you get them.
I haven't seen them yet.
Yep.
And second, will the reports be audited, or will it be compared to filed income tax? How will we know that what they're reporting is accurate?
So all of this will be done through our Medicaid fiscal auditing contractor.
Okay.
So we're setting up that vehicle with our auditing contractor.
Not that I
ensure.
didn't trust them, but
I understand.
the private equity firms have been a little bit of a problem. So
Yes.
thank you for that testimony. Do I have any questions for Dr. Moran? Senator Ellis?
Yeah, thank you, Madam Chair. Thank you for answering my questions. I apologize for jumping ahead. I didn't know.
I'm so glad you did, Senator Ellis.
So you mentioned Medicaid auditing contractors? Who are those people?
So we work with an external vendor, Myers and Stauffer. So they're an external auditing cost reporting firm that we use specifically here in this. They do our cost reporting right now.
Is that
It's an accounting firm.
Okay.
Yeah, accounting auditing firm.
Okay.
Yep.
I didn't realize that specialty existed, so, yeah, thanks, Lord.
Yep.
Okay.
Thank you, Senator. We have one more favorable with amendment, and it's Christina Moore at the table.
Thank you, Chair Beidel and members of the committee. My name is Christina Moore, and I'm a chief attorney at Maryland Legal Aid. I lead the Baltimore City Administrative Law Unit with expertise in administrative law and public benefits. And I'm pleased to request a favorable report of this bill with clarifying amendments. This bill would require skilled nursing facilities to spend at least 75% of its revenue on direct care workforce wages. As I testified last year, Maryland Legal Aid has seen a major change related to purchases of skilled nursing facilities. Increasingly, these healthcare facilities are being purchased by private equity firms, which seek to maximize profit at the cost of ensuring adequate staffing and acceptable patient care. According to the Maryland Healthcare Commission's 2023 study, 74% of skilled nursing facilities are owned by a for-profit company. By way of example, Maryland Legal Aid represented Mr. M, an older adult who was admitted to a skilled nursing facility over a year and a half prior to the representation and had stabilized from his lower leg amputation, which had been complicated by antibiotic resistance. In that recovery and stabilization time, no one assisted him with an application for Supplemental Security Income, SSI, which would have opened opportunities for him for housing. Rather, at the time he no longer met criteria for long-term care medical assistance, the facility intended to discharge him to a homeless shelter, blaming social work turnover for their failure to prepare him. In this instance and many more, adequate staff would have improved our client's experience, reduced his reliance on institutional care, and allowed our client to reinvest in the community that he wanted to return to. We support this bill with two amendments. First, we recommend defining revenue in the statute. I think that alludes to a study kind of to explore what revenue is. We also recommend that direct care professionals include behavioral health workers. This bill is a crucial step toward ensuring delivery of care remains prioritized over profits. Thank you.
Thank you, and thank you for submitting your amendments in writing. Appreciate that. Do I have any questions for Christina Moore? I don't see any questions. Thank you both for your testimony. Next, we have two unfavorables. Allison Siborowski, which I never say that right, Allison, and I apologize. I try. With a maiden name like Grabowski, I should get that right, but I don't. And Dana. Thank you. Kaufman.
Good afternoon, Madam Chair, Mr. Vice Chair, members of the committee. For the record, I'm Dana Kaufman. I'm here on behalf of Lifespan Network. We initially opposed the bill, but we understand that there has been an amendment that would replace the bill. I want to clarify some information that was said up front about the cost reports. So Maryland has a very detailed nursing home reimbursement system that is based on cost reports that must be submitted on an annual basis by the nursing homes. It is this cost report that is actually then used for the distribution of the budget. So the budget's a pie. The nursing home budget is a pie, and then the nursing homes get the slices. And those slices are based on the cost reports. The cost reports are extremely detailed. They're in 4 cost centers. Those cost centers are basically patient care, capital, routine and administrative, and other patient care. I don't think that there's a cost that happens in a nursing home that is not put on this cost report. Those cost reports are actually audited by Myers and Stauffer every 2 years when rebasing occurs. So I did want to clarify that. And again, it's Myers and Stauffer who does the cost reports. When I look at the amendment, and I know that it hasn't been given, our main concern is making sure that there is consistency. We don't have an issue with a study done, but we want it to be consistent with the cost reports. It is interesting because when you do see the amendment, it talks about that the department shall review shall review the data for nursing homes that participate in the medical assistance program. It does not talk about changing the cost reports or making templates, so I'm a little bit unsure really what we're talking about now. I was kind of taken by surprise there because, again, those cost reports are so detailed. I don't think we need to recreate the wheel. That information is all within the health department. So if we need to find a way that they can report that information. And the last point I just want to make is the private equity. Remember, we passed the bill on private equity and transparency. It's been implemented. Maryland Healthcare Commission now has the authority of whether to approve or disapprove or put qualifications on a change of ownership. So I don't want to muddy the two. With this, we have dealt with that issue before, so thank you.
Dana, but that doesn't apply to ones that have already transferred to a for-profit.
That does not. It does.
Yeah.
It deals with the CHOW. You're exactly correct.
That was a bill to go forward.
Yes.
Thank you for your testimony. Allison?
Thank you, Madam Chair, Mr. Vice Chair, members of the committee. My name is Allison Siborowski, here today on behalf of Leading Age Maryland. We respectfully request an unfavorable report on the bill as written. I just received the amendments about 2 hours ago, and so I have not had a chance to review them. I will say that we are in support of further evaluation of the current state of wages and benefits in Maryland nursing homes. I just want to make a couple of points. First, in general, nonprofit nursing homes have higher staffing ratios than for-profit peers, but many are only able to do this through support of revenue from other service lines and philanthropy. This bill would further strain nonprofit nursing homes who are already shrinking in numbers. I also want to ensure that in any further evaluation or study that we take into account the true cost of quality care. I'd like to point out that the connection between the percent of total revenue that goes towards a certain portion of staff wages and benefits is not directly tied to quality, including staffing quality metrics. Several of our members this past week pulled financial information to calculate the percent of their current nursing home revenue that's spent on direct care wages and benefits as defined by the bill. And as Dana noted, there are some challenges with some of the definitions not being clear. We want to be sure that we're comparing apples to apples. Several of these providers came in around the 50% range. Several came in between 60 and 74%. None were above 75%. However, all of these communities have 5-star staffing ratings from CMS, and when compared to other nursing homes, both here in Maryland and nationally, have higher wages, significantly lower turnover, higher staffing ratios, and higher weekend staff hours. So in conclusion, an arbitrary requirement that does not accurately take into account the true cost of quality care would be detrimental to providers, staff, and residents. We look forward to continuing to work with the proponents and bill sponsor and reviewing the amendments. Thank you.
Thank you, Allison. Do I have any questions for either of these witnesses? Seeing no questions, thank you very much. And finally, we have one virtual witness, Christopher Meyer, favorable. Hi, Christopher. You can turn off your mic and do a presentation. Thank you.
Thank you, Chair Beidel and members of the committee. My name is Christopher Meyer. I'm a research analyst at the Maryland Center on Economic Policy. In strong support of Senate Bill 679 as modified by the sponsor amendment. I'm going to tell you two things that you already know. First, nursing homes are an essential part of Maryland's care infrastructure. Our entire long-term care field, though, is experiencing a severe workforce shortage. This shortage is only going to get worse as our population continues to age, and the shortage is driven largely by insufficient wages and subpar working conditions. The second thing you already know is that information is important. That means having accurate data. It also means using the data to generate insights and practicing transparency with those insights. Not everyone agrees that information is desirable. Over the last month, we've watched as Donald Trump and Elon Musk have sought to dismantle the federal government's data infrastructure. Let's take a better approach in Maryland. We have some information about the nursing home workforce in Maryland as of 2023 based on federal data. We know that 71% of healthcare support occupations workers like nursing assistants and personal care aides in Maryland are people of color, including 60% who are Black. 83% of those workers are women. We also know that among healthcare support occupations workers, which is the largest subpart of that workforce, the median annual pay is less than $39,000. This means less recruitment and retention and less access to care. But there's a lot we don't know. We don't know nursing homes' cost structure. We don't know if they're employing sufficient staff to meet residents' needs and ensure tolerable working conditions, how much they're spending on care, and how much they're extracting profit. This bill would expand or would fill that knowledge gap without creating any more responsibilities for nursing home operators. Thank you. I request a favorable report.
Thank you, Christopher. Do I have any questions for this witness? I don't see any questions. Thank you for your testimony. That ends the hearing on Senate Bill 679. And next, we're going to go to Senate Bill 594, Senator Ellis. Public Health, Use of Opioid Restitution Fund and Training under the Overdose Response Program. And your panel includes Ann Seacott.
Can I sit next to you? Yes, please. Thank you, Madam Chair, Vice Chair, committee members. Senator Arthur Ellis from Charles County District 20 here to present Senate Bill 594, which seeks to improve racial equity and simplify the authorized uses of opioid settlement funds in Maryland. This legislation streamlines the current multi-line breakdown of authorized uses into clear, consolidated categories that prioritize compassionate, evidence-based substance use disorder services, training programs across the entire continuum of care. Additionally, Senate Bill 594 adds pertinent language to acknowledge and address disparities in access to treatment and health outcomes for racial minorities in Maryland. Furthermore, Senate Bill 594 strengthens Maryland's response to the opioid crisis by ensuring that all individuals have equitable access to treatment and recovery resources. This legislation prioritizes evidence-based, community-driven, and compassionate approaches to substance use disorder care. It also ensures that opioid settlement funds are allocated effectively to benefit the communities most impacted by the opioid crisis. I just want to bring attention to the fiscal summary. It says, the bill primarily alters the purpose for which existing funds may be used to align with the allowable uses under the National Settlement Account Agreement. No existing programs are affected under the bill. As such, there is no material fiscal or operational impact on the Maryland Department of Health in response to this bill. Therefore, colleagues, I urge a favorable report for Senate Bill 594.
Thank you, Senator Ann. Go ahead.
Thank you, Madam Chair, members of the committee. I'm Ann Seacott, testifying on behalf of the Maryland chapter of the National Council on Alcoholism and Drug Dependence. We want to thank Senator Ellis for sponsoring the bill. This bill is very simple. The intent is to better align the uses of the state's opioid restitution fund with the national settlement agreements and national judgments. You all passed a law in 2019 creating the opioid restitution fund before these settlements happened. Inadvertently, some of what we have in statute limits how the money can be spent based on these settlements. So what we have done here, and there is a slight drafting error, what we've done here is take out the enumerated uses of the bill. You will notice on, if I pick up the right bill, on page 3, there's a bracket at the bottom on line 31. We are offering an amendment to please move that bracket up to line 21. So that will take out all of the enumerated uses under that number 1 on page 3. And you'll see the information above it, the added language in letter F. That's the language that we intend to have make sure that Maryland's uses match the national settlements. So there was some confusion, and I think a number of people were concerned we were taking things out. It was not the intent whatsoever. We just wanted to take out the long list and say it needs to match these things. The other two things the bill does very quickly is it does add that there needs to be a focus on addressing racial disparities, because while we have made progress in reducing the number of overdose deaths, the racial disparities still exist. And then we want to talk a little bit about compassionate overdose response in our trainings on the use of naloxone. With that, we ask for a favorable report with that one little movement of a bracket.
Thank you, Ann. There's a gentleman, we don't have you listed. Did you sign up?
Yes, ma'am.
What's your name?
John Torsch, the Daniel Carl Torsch Foundation.
And you're sure you signed up?
Yes.
Spell your last name for me?
Torsch.
Okay. Wait just a minute. Wrong bill?
No.
Okay.
Someone else signed up.
Oh, okay.
My mother submitted written testimony, and under the sign-up, it just said Daniel Carl Torsch Foundation, so I'm representing.
Okay. That's what happened.
Okay.
You're fine, go ahead.
Is that what it
Thank
is?
you.
Okay. Thank you, Madam Chair, members of the committee. My name is John Torsch. I'm the co-founder and the program director of the Daniel Carl Torsch Foundation. We fully support bringing in line the national, basically the national settlement agreement into Maryland. The things like housing and transportation and some of these other allowable costs are services that we provide through our organization to between 350 and 400 people a month, so we know how valuable they are. And it seems like that's a very standard ask. All we're really asking for is to bring it up to the national standards, and I guess some of the things got left out last time. In terms of the compassionate overdose response, we were the second opioid response program approved in Maryland in 2014. And I've personally trained several thousand people in overdose response. We distribute roughly 5,000 to 6,000 doses of naloxone every year. And the landscape of drugs have changed, fentanyl and xylazine in particular. So the way that we respond to overdoses has changed. And what we've learned over the years is that high dose and long-lasting naloxone is not only unnecessary, it's often harmful and counterproductive to responding to an overdose. When an overdose is a respiratory arrest, it's a respiratory emergency. The goal of an overdose is simply to restore respiratory function. It's not a Pulp Fiction moment where we're expecting people to just come out of it and wake up these days. And with these longer lasting agonists, these in types of overdose reversal drugs, people tend to vomit. They become disoriented. They become very painful. It's called precipitated withdrawal. It comes on very fast. It's basically a withdrawal from an opioid that would normally take 3 to 4 days, comes on instantaneously. So when you hear stories about people becoming very violent and agitated and aggressive after being revived from an overdose, it's usually because the person used too much naloxone too quickly, or one of these stronger agonists were used. So we didn't ask for it in Maryland. We don't need them in Maryland, and we don't really want them. So part of this training is just to make sure that the overdose response programs that are providing naloxone and overdose reversal training in Maryland are using best practices. We're encouraging rescue breathing. We're encouraging slow use of naloxone, helping someone come back and not. The goal of responding to an overdose is not to put a person into pain or withdrawal. It's to save their life, and that's what this legislation will help prevent and do. Thank you.
John, thank you for your testimony, but for the work that you and your mom are doing. I appreciate that information. Do I have any questions for this panel? Senator Ellis?
Yeah, just want to add the amendments that Ann spoke about, Ms. Segal. I have them in writing, submitted them to the committee. So, yeah, you're welcome. Yes, ma'am. Okay.
We have two favored with amendment, Bill George and Sarah Sample.
Hang on 1 second. Oops, I forgot about it. I'm glad you reminded me.
Good afternoon, Chair, Vice Chair, members of the committee. Bill George with the Maryland Municipal League here today supporting Senate Bill 594 with amendment. And that is the amendment that was described by the sponsor panel. In 2021 and into 2022, MML, MACO, and the Attorney General's Office negotiated a state subdivision agreement that would funnel some of the money coming from these settlements to local governments in a prescribed manner. So the expenditures coming out of the Opioid Restitution Fund do go to local governments in part. So that's where our impact comes in, and it is aligning with the national settlements is where we see more flexibility being provided to local governments for the use of these funds. This doesn't mean elimination of guardrails, of course. The national settlement does have eligible uses. They're just a little bit more expansive than what we see in the code. And as was explained by the sponsor panel, as this was set up before the first settlement was even finalized, so as the agreements have gone on, they have the eligible uses have become a little bit more expansive in the settlement agreements compared to those in the code, and we've started to see a little bit of conflict between the two. So that being said, we asked for a favorable report with the sponsor amendments. Thank you.
Thank you so much for your testimony. Sarah?
Thank you for having me today. My name is Sarah Sample. I'm here on behalf of the Maryland Association of Counties, and we support with amendment Senate Bill 594 as well. We think this is a very good bill. It helps eliminate confusion when it comes to what it says in the settlement agreements and what the statute says. And the amendments that were offered by the sponsor panel, we completely agree with those, and that was our major concern. But otherwise, this is a great bill. It expands resources and training for overdose issues, which I think will be very, very useful in terms of saving lives, and then also addressing the racial disparities. We think that that's great and absolutely necessary. So this is a good bill. We're happy with the amendments, and we are happy to support with them as introduced. Thank you.
Thank you. Are there any additional questions for this panel? Seeing none, thank you so very much. This ends the hearing on Senate Bill 594. Sorry. Senate Bill 793, Senator Mouse and Eric Galley. Is Eric here? Oh, yeah, he's here. Let's see. Is Stephen Thomas also here?
He's right here.
You want to come on up to the panel with them, Stephen? Thank you.
Thank you, Eric. Thank you, David. Mr. Vice Chair, Chair, colleagues, it's an honor to be able to present Senate Bill 793 today. It's titled Public Health Opioid Overdose Reversal Drugs. This bill, Senate Bill 793, requests that the FDA-approved brand Opvee be placed on the standing order list as a drug which can be obtained without a prescription for use on an overdose patient. Opvee, which contains nalmefene, is a strong pain reducer chemically related to the opioid naloxone, which many of us recognize under the brand name Narcan. But Opvee is stronger. The key difference between the drugs lies in how long they work. A dose of Opvee nasal spray keeps working in the body longer than the dose of Narcan. This legislation is an effort to add an FDA-approved and effective tool into the hands of those who in that moment of emergency action may not know exactly what the patient has overdosed on. I'd urge your colleagues your support for Senate Bill 793. As you may recall, this was a fight that was started by our former vice chair, and I'm honored to be able to pick that fight up and carry on where the vice chair left off. She moved off to Baltimore County. And I'll just share a personal vignette. I know the world of drug overdose is changing. I know that it's controversial. This legislation is only intended to help. Overdose is life and death. I don't know really how you can equate pain and comfort when you're talking about saving a life. And knowing that you have the best available medicine at the ready, I think is a night and day difference, especially for our first responders who now are carrying multiple doses of Narcan because they don't know what they're dealing with when they come upon an overdose. More frequently than not, they're using more than one dose. There are obviously both sides to every argument, and you'll hear both sides today. But with that, I'll turn this over to my expert panel, Mr. Chair, and I appreciate everyone's attention and appreciation for this important issue.
Thank you.
Thank you, Mr. Vice Chairman. It's a pleasure to see you up there. Congratulations. My name is Eric Galley, and I'm here today representing Indivior Corporation. They have this overdose reversal medication called Opvee that you first heard about last year, and now you're hearing again this year. It's been approved by the FDA and is specifically approved by the FDA for the stronger medicines, the fentanyl and the synthetic medicines, for about 2 years from now. And we're talking about putting it into the standing order in Maryland. And I will just give you just a few facts. Of the 37 states that have standing orders, 20 include Opvee either by name or with the language, all FDA-approved products. So a majority of the states that have standing orders already include Opvee. Now, among the other states that don't have standing orders, 13 of them have made Opvee available in the system that they use for all of these things. So we look at it as though 33 states have made Opvee available. So you might hear that people are worried about it, that it might be dangerous, that there might be bad outcomes. But 20 states have been doing it in their standing order for about 2 years now. And we checked around and we haven't heard anybody saying there's been adverse outcomes, there's been any problems. They're all just moving along and they're doing it. And I would urge you, as a last thing, to take a look. I downloaded all of the standing orders that we have for you. This is just a few of them. I got cut off by my printer in the M's, but this has all been downloaded for you. I would urge you to just take a couple of these standing orders from the different states and read them, and you will see how thorough and thoughtful they are. They're not just throwing Opvee on a list and saying, do whatever you want. They're thinking it through. They have recommendations. They're doing things that we should be able to do. We would urge you to help us join the 20 states and have Opvee on the standing order. Thank you very much.
Thank you, Mr. Galley. Mr. Stephen?
Thank you, Chair. Vice Chair Hayes. My name is Stephen Thomas. I'm a professor in the School of Public Health at the University of Maryland, and I direct the Maryland Center for Health Equity. I'm here speaking as a Maryland citizen, and it feels a bit like deja vu because I was here last year on this same issue, and it was in this room when I received notice that a dear friend's son had died from an overdose. A healthcare practitioner couldn't bring her son back. She had Narcan. It wasn't strong enough. She's not alone. According to the U.S. Attorney's Office and the DEA, more than 2,000 overdose deaths from July 2023 to June 2024. More than 1,600 of those deaths were from fentanyl. It's time to update. And I'm having just a trouble understanding why there's opposition. If we put saving lives first, complications of recovery, complications of overdose recovery, we have the best medical facilities in the world. At least they're alive. Now, I have an article here titled Stronger, Longer, Better Opioid Antagonists. It's time for us to update the standing order. And the beautiful thing about it is that it's an opportunity to get people into care. So again, I have friends and loved ones wondering, why is there opposition from my friends in public health opposed to giving our first responders all the tools on the table necessary to save lives? That should be the priority. And with that, I urge you to, this time around, please favorably support this bill.
Thank you so very much for your testimony. I believe Senator Lamb is going where I'm going. If you look at the testimony, Senator and panelists, it doesn't necessarily have objection to expanding the various formularies. It says that the way the bill is drafted may appear to be broader than what you guys are asking for today. So I don't know if you've had a chance to read the testimony or not.
We have not, but we will look into that.
Yeah, if you could take a look at it. It seems like there's some drafting issues that goes beyond, it seems like, what your testimony.
You mean beyond all FDA approved? 'Cause ours is FDA approved.
Right. Got it. One second, Mr. Stephen. Let me turn it over to Senator Lamb.
Thank you, Mr. Vice Chair. So certainly appreciate the goal of this bill to address kind of the opioid crisis we've seen. Obviously, we have a very real issue here. And over the last couple of years, I've had many conversations with a lot of researchers and folks that are working in the overdose prevention field. But through those conversations, I'm concerned that the research isn't actually there to justify this bill. That under the bill, we're requiring, this is a requirement of licensed healthcare professionals and providers to add a standing order to all forms of reversal drugs, requirement. What should a licensed provider do if in their own best clinical judgment, it's not medically appropriate to do so? This is overriding that clinician's medical judgment. So should that clinician just not issue the order, or should they issue an order that they don't believe is in the best judgment, in their best judgment, clinically justified based on the research and what they're seeing with that individual?
Well, I would say the standing order is a state creation. You created it in state law. We would rather, we've had a lot of discussions with the health department and specifically with Dr. K, and I was with him he was trapped with me for hours yesterday, and we were talking about this, and we're working on some things. But the standing order, it was a creation of the state. It's in code. So we're asking you to make an amendment to the code as it exists.
But I think there's a difference in requiring this in all instances. And it's really creating a scenario where non-clinicians are making judgments about which reversal drug is best for these folks versus a standing order, and where a provider is making a decision that's generally what's best for that individual or what's best for the most appropriate drug in that instance. So it seems as though we're putting lay people or folks that are non-clinical in this clinical decision-making structure to help make this, to require this decision to be made.
Well, but we've heard from a lot of first responders who are usually doing a lot of these rescues, and they aren't clinicians. That is true. And what we've heard is that a lot of them will have like 8 doses of naloxone and 2 doses of Opvee. And if they get to the site and they're told by whoever's there, we know he was using fentanyl, or we know he was using some other of the synthetic drugs, they might go with the Opvee. If they're not given any guidance, they tend to go with the smaller dose of naloxone, because we certainly wouldn't suggest that naloxone shouldn't be the standard for the typical situation. We're just saying it's a niche market and it's hard for people to get it if it's not in the standing order.
I think you're conflating 2 different areas here, because what EMS is operating under are different protocols. They're not operating under standing orders, right? So they're operating under a different protocol. And right now, a health department, a health officer, could, or health department doctor could order or include all these reversal drugs in the standing order if they choose to do so. This is a state overlay, a mandate requiring that this be included, but it could be done at the local health department level, and so, I just want to make sure that that distinction is clear there, that EMS is operating under protocols under MIMS, not under standing order protocols.
Right, but they all say, oh, I'm sorry, I didn't mean to interrupt. They all say that they know they're not going to, they like to get the stuff for free. They get the stuff from the state, and that if it's not in the standing order, they're not going to be able to order it. They're going to have to pay for it.
Earlier in this testimony, it was said that a lot of states include this drug in their standing orders, but that's done not by statute, not by law, I presume, but really at the judgment of the healthcare professionals in those states that issue the standing orders, right? Whether that's the Secretary of Health or in localities, that's the health officer. That's how it's included in standing orders, not by law.
3 of them were done by law, and the other 17 were done by the judgment like you're talking about. But there are 3 that were done by code.
But the vast majority of them are done by just a healthcare professional making that decision, who has the authority to expand the standing order to include that. Right.
That's true.
And I'm noticing in the bill folder here that I don't see any clinical groups supporting this or any clinicians. So I just find that very interesting.
Thank you, Senator Lamb. Are there any additional questions? Seeing none, thank you all so very much. This ends the hearing on Senate Bill 793. Next, colleagues, we're going to go to Senate Bill 676, hear from Senator Guile, Robin Elliott. And just note, Robin, you're signed up as favorable with amendment, correct? Okay.
Good afternoon, Mr. Vice Chair, members of the committee. For the record, Dawn Guile here to present Senate Bill 676. This bill would strengthen perinatal care standards across Maryland by requiring MDH to adopt regulations ensuring that all hospitals providing obstetrical services and freestanding birthing centers meet or exceed the Maryland perinatal system standards. While Maryland has long recognized the importance of perinatal care, there is currently no statutory requirement ensuring that all hospitals and freestanding birthing centers adhere to the Maryland perinatal system standards as a condition of licensure. These standards, developed by the MDH Perinatal Clinical Advisory Committee, reflect the latest national guidelines set by the American Academy of Pediatrics and the American College of Obstetricians and Gynecologists. This bill ensures uniformity and accountability in maternal and neonatal care across all facilities, reducing disparities and improving health outcomes for families in Maryland. Maryland has already made significant strides in improving maternal and neonatal care, but gaps in standardized enforcement remain. By aligning hospital and birthing center regulations with the most current perinatal care guidelines, we can ensure that every mother and baby in Maryland receives the highest level of care, regardless of where they deliver. This bill is a proactive step in ensuring that all birthing facilities in our state provide consistent, high-quality care for mothers and newborns. This is about setting a clear, consistent expectation for perinatal care across the state. We have worked closely with MDH and have adopted amendments to address concerns raised by the department. We are still waiting on them from drafting, but we will be sending them to the committee as soon as we have them. In summary, Senate Bill 676, as amended, would require the Maryland Department of Health, in coordination with MIMS, to adopt regulations establishing minimum perinatal care standards that meet or exceed the Maryland perinatal system standards for each hospital that provides obstetrical services and each freestanding birthing centers. And for these reasons, I would respectfully request a favorable report on Senate Bill 676.
Thank you so much for your testimony.
Good afternoon. Robin Elliott here today on behalf of the American College of Nurse Midwives, the Maryland affiliate. And I'm just going to share some of the institutional history. These requirements were developed back in the late 1990s, early 2000s. I was actually at the Department of Health and worked with Dr. Russell Moy. I don't know if anybody remembers him. He was a wonderful OBGYN who worked at the department. Developed these standards to make sure that when there were transfers of care to hospitals, that those hospitals of individuals who were giving birth, that those hospitals were equipped to handle any perinatal emergencies. So these regulations or these standards have developed over time. So what the Senator's bill does is it requires them to be actually adopted in regulation in the most updated format. The amendment that I suggested is just an observation that the requirements for hospitals and freestanding birthing centers would be a little bit different. Birthing centers don't have perinatal care units. Happy to work with the committee and appreciate the opportunity to testify.
Absolutely. Thank you so much for your testimony. Senator Lamb.
Thank you, Mr. Vice Chair. So just going through the bill folder, looking at the letter from the nurse midwives, I guess it notes here that there are no current birthing centers in the state, and the standards that this bill, if enacted, it seemingly would make it harder for future birthing centers to open, I guess. You know, in my opinion, would like to see more birthing centers open so that we can have more folks move away from high-risk options such as home births, which we've heard a lot about in this committee. So I guess, you know, question, maybe it's more to the sponsor, would you be open to an amendment from the nurse midwives to remove birthing centers?
I mean, I couldn't agree more that I would like to see more birthing facilities in the state. Honestly, I might have to defer a little bit. My cross-file in the House is Chair Pena-Melnick, and I would probably prefer to consult with her a little bit to get a little bit more information about the perspective, because I know that she's been working really closely on this bill, including with MDH. So in short, I can't commit to necessarily anything at this point without a little bit further information and consulting with her as well.
Okay, and just to, as I mentioned, there are no birthing centers currently in the state.
Absolutely.
Right? And so
Yeah.
it just seems like to have a broader umbrella that covers them seems like it's not necessary at this time, and maybe something that can be looked at over the interim as to whether or not birthing centers should be brought in under the same umbrella of hospitals, which this bill does.
Yeah, I appreciate that concern. I was receiving care from a birthing center on my last child in Arnold that closed, and was very sad when it closed. So I absolutely agree with you. But again, I would hate to commit to something openly here on the record without having a greater discussion about the position on that. So thank you.
Thanks.
Thank you, Senator Lamb. Are there any additional questions? Seeing none, thank you so much for this panel.
Thank you, Mr. Vice Chair.
Indeed. We do have Laura Bogley signed up as unfavorable. Laura, are you here? Where is Laura? Laura Bogley, going once, going twice. This ends the bill hearing on Senate Bill 676. Colleagues, next we have Senate Bill 981. Senator Hershey will be joining us momentarily, but not to delay it, I'd like to call up his supporting panel, and then whenever he arrives, accommodate him as such, all right? So let's call up Megan Renfrew. I apologize if I butchered that. Okay. Anthony Davis, Marceline White, and Bridge Dumaze. Bridge. Sorry.
It's okay. You're good. You're good.
Yeah, I'm sorry. The sponsor, once he arrives, will have unlimited amount of time. Each one of the panelists will be timed 2 minutes. So please stay within the time, and you all should proceed as you wish.
Okay. Good afternoon, Chair and members of the committee. My name is Megan Renfrew. I'm here representing the Health Services Cost Review Commission. This bill improves consistency in hospital financial assistance policies across the state. I'm going to focus on a few aspects of the bill. It accomplishes a number of things, but one of the things I think is most important is that it sets a standard for the discount that hospitals provide to patients who are eligible for reduced cost care. Right now, patients receive different amounts of financial assistance depending on where they seek care. These differences are substantial. This bill contains minimum standards for the discounts to improve fairness for patients who live in different communities. The bill also ensures that the method used for calculating income to determine eligibility for free and reduced cost care is the same as the method used to determine the monthly payment amount for income-based payment plans. This leads to better consistency in how those things are determined. I'm expecting questions today about the cost of this bill. This bill may increase the amount of financial assistance that's provided to patients, and I think that's a positive outcome. HSCRC's existing policies will automatically adjust the amount of revenue that hospitals receive for those increased costs. These costs will be included in the rates paid by Medicare, Medicaid, and commercial insurance, and I'm happy to answer more questions about that. I think this is an important step towards decreasing the burden of medical debt on Marylanders, and we urge a favorable report on this bill, and I see that the sponsor has arrived. Yeah.
Indeed, he has. So, Senator Hershey, not to lose any time, we proceeded with your panel. We've only heard from your first panelist, Megan, but if you will, of course, you have unlimited time and may present Senate Bill 981 before this committee.
Mr. Chairman, I was going to just say me too, if I could, to move things along a little bit. But I can just give a brief, again, statement if you don't mind. For the record, Senator Steve Hershey, here to present Senate Bill 981, sorry. Just very quickly, this is an issue that we've been working on for a number of years. In fact, Mr. Vice Chair, you and I had worked on this before. Originally, your bill, we've made some modifications last year as well, too. So something that we've all found very important. Just a little bit of stats with this. In 2023, 14% of Maryland households, almost 876,000 households, have a medical debt they are unable to repay. Of those households, Black and Latino households disproportionately hold unaffordable medical debt. The impact of medical debt on financial security and overall health can be significant. Medical debt has been found to be associated with food insecurity, decreased ability to pay for utilities, and eviction or foreclosure. Among adults with high medical debt, 63% of adults reported having to cut back on spending for food, clothing, basic household items in order to pay down their debt. Addressing medical debt at its source by ensuring clear and consistent process for financial assistance policies is one of the best ways to reduce onerous medical debt. And broadly, this bill will create minimum level of subsidy for patients eligible for reduced cost care, prohibit reporting to credit agencies, prohibit hospitals from suing patients who owe less than $500, and prohibit signing under seal. Mr. Chair, again, this bill has already been heard in the House. As a result, there are 2 amendments that are in the package that we've agreed to. Finally, we've also been working with the Maryland Hospital Association on this as well. We're still negotiating their concerns, but we hope that by the time we're done with this, we can have agreement with all parties. So with that, Mr. Chair, I ask for a favorable committee report.
Indeed. Thank you so much for your testimony. Who wanted to go next? You, Bridge?
Hi, good evening, Senators. My name is Bridge Dumais. I'm the political coordinator with 1199 SEIU United Healthcare Workers East. We are the largest healthcare workers union in the nation, representing 10,000 members right here in the great state of Maryland. We urge a favorable report on SB 981, the Hospital Debt Prevention Act, to standardize hospital financial assistance, prohibit medical debt reporting to credit agencies, and ban frivolous medical debt lawsuits. Too often, patients avoid seeking care because they know they can't afford it. When they delay going to the hospital due to fears of debt, it can cause conditions to worsen, which ultimately makes it more difficult and expensive to treat. Maryland has the longest ED wait times in the entire country, and our hospitals are chronically understaffed. The best way to reduce ED wait times is to remedy the short staffing crisis by giving workers a real voice in crafting a safe staffing plan, but the state must use all of the tools in its toolbox to mitigate these issues. That includes passing this bill to relieve the financial burden on patients. A study by the AFL-CIO and National Nurses United entitled Preying on Patients found that Maryland's nonprofit hospitals sue patients to collect small dollar medical debts, even patients who should have received free or reduced cost health care. The study also found that many sued by hospitals were their own workers, particularly workers in departments like environmental services and dietary. This includes members of 1199. One worker was sued for just $98. It's unacceptable for hospitals to underpay workers, making it more difficult for them to afford health care, then to take them to court when they can't foot the bill. Healthcare workers across the entire care team make sacrifices, facing infectious diseases and working in dangerously short-staffed departments to provide high-quality care for our loved ones. They should not face punitive lawsuits when they cannot afford the care that they need. Please vote yes on SB 981. Thank you.
Thank you.
Good afternoon. Good afternoon. My name is Anthony Davis. I'm a Director of Advocacy for Consumer Law at Maryland Legal Aid. I thank the Senator Hershey for inviting us to testify on this legislation. Maryland Legal Aid strongly supports Senate Bill 981, and we urge a favorable report. We thank the legislator for continuing to provide reform in this space and to help make it easier for those who need medical care to get it and to not be fearful of how to pay. I typically deal in housing. I typically try to keep families together, keep a roof over their head, and I deal with a lot of bankruptcy. Clients who come to me and we're going over their cases, it's heartbroken because the young lady brought her children in and they had sniffles and sneezes and such, as children do. And she said she was, doing her best to kind of maintain keeps the fever down and such. But the next time I met with her, she wasn't with her children. Her children had developed pneumonia. I asked her why, a concerned parent myself, I asked her, why she didn't go to the doctor sooner when she noticed temperatures and such. And she says, because I just can't afford it. And this is really the face of the clients that we serve. We're talking single people who are not earning more than $20,000 or so, families of 2 or 3, which are usually single mothers, or young people aging out of the foster care system and such, that we find who are brought into court for lawsuits regarding medical care. They don't know how to manage it. They weren't giving notices about what they qualified for or reduced costs. So this legislation goes a long way in reforming that and helping the clients that we see every day. So I hope I can put a face to some of the people that come in that really urgently need this care. Thank you very much, and we urge a favorable report.
Good afternoon, Chair, members of the committee. For the record, my name is Marceline White, Executive Director of Economic Action Maryland Fund. Economic Action advances economic rights, equity, housing justice through research, education, direct service, and policy advocacy. Our direct service programs serve every county in the state. We are here urging a favorable report on SB 981, and I want to thank the Senator for bringing the bill. This bill builds on the good work that this committee has done for a number of years. So this is the next step in helping to put patients first. As you've heard, medical debt is an issue in this state. As you all well know, the cost of living has increased dramatically in the past few years. So most families are paying 22% more than they were 4 years ago. This means there are more families than ever that may need to rely on reduced cost care and financial assistance. Yet the threshold to receive reduced cost care varies from hospital to hospital. So I could go to a hospital in Montgomery County and qualify and not qualify in Baltimore City, or the discounts I receive could be different. This standardizes it and creates fairness and equity across the state. We know that this committee and the General Assembly has done good work on financial assistance, yet many people still do not know. We did a survey in 2023, and 29% of Marylanders polled were unaware that financial assistance policies were available. This makes it very clear to patients that financial assistance is there for them. It expands healthcare access, increases transparency, eliminates harmful practices such as suing for very low amounts of medical debt. What it won't do is harm hospitals' bottom line. Maryland hospital systems will still be compensated through the global budgeting for this increased financial assistance. It also is a lower threshold and a more modest approach for banning lawsuits than other states like New York. This is just for the most low-income patients. And we believe that it is important, and for all these reasons, we urge a favorable report on Senate Bill 981.
Excellent. Thank you so much for your testimony. Is there any questions for this panel? I know it's tempting, right? Thank you all so very much. We have one more panelist. I don't see Jake. Jake Whitaker.
He's stuck down at JPR. Mr. Vice Chair, would you mind if I present an MHA?
Is this a compelling testimony in this amendment? Come on Andrew. Come on, Andrew.
I think I'm the last witness on the last bill of the day.
You are absolutely.
Okay.
So recognize the moment. Thank you.
Yes, sir. All right. Speed talking. Mr. Chairman, members of the committee, again, for the record, Andrew Nicholas on behalf of the Maryland Hospital Association. We are here in supporting the bill with amendments. First, I want to thank the sponsors for the bill. You heard the sponsors say MHA has been involved in discussions and negotiations with this on this bill since the summer. Those discussions are ongoing, and so I just reference that to say, we might end up in a different place than we are right now, but as of today, we are support with amendments. We fully support every aspect of the bill aimed at reforming medical debt collection practices. That is something our members are leaning into, and so I have no objections to any of those. our concerns with the bill are really simply around some of the aspects of the bill may expand access to uncompensated care for additional folks. That does increase rates. That uncompensated care gets spread around everyone. And so there is an impact to all carriers and all payers, including Medicaid. And especially right now, just say with what's going on at the federal level, there's a lot of uncertainty with what might be coming down. We've heard a lot of potential cuts to Medicaid, and that could impact a lot of Marylanders. And so if we are in a situation where actions at the federal level result in Marylanders losing their Medicaid coverage, we might be having a very different, broader conversation about how to ensure that more people continue to remain covered. And so just wondering, thinking that we might want to have all of our resources available to ensure we have coverage for those folks who lose it. And so, with that, I'll submit, and that is our testimony.
Excellent. Thank you so much for your very precise testimony. We appreciate it. Are there any questions for this panelist? Thank you so very much.
Thanks, sir.
This ends the bill hearing on Senate Bill, where were we? 981. If everyone could please just keep your seats just for a minute, give us